able to cope with the different stressors of the life. And the next come how you are striking a balance with your environment. Maybe immediate environment, maybe your community, your workplace, your learning environment, everywhere. You should be within the defined social norms. So that is very important. And the third is you should be a productive citizen. If all of the things are going together, then we can say the person is mentally healthy. How do you assess it? We don't have a definitive investigation. We can do certain clinical examination. We go for a psychiatric history. Then we go for a MSc. Mental status examination. We go for MMSE, mini mental status examination. We can apply certain standardized psychometric tools. And then, if we need, we can go for certain physical investigation, because at the end of every diagnosis, you have to exclude confidently that there should not be existence of any physical illness, just to pinpoint the diagnosis of a functional mental disorder. So this is all about the mental health. Next. So you can see mental health is as important as physical health. That is what I am going to stress. That is what I am saying for, the last couple of minutes, what I am stressing. You should not, because a good physical health with an inadequate or inadequacy on the part, there is some inadequacy in the mental health itself. So it's not going to give you a full health status. Next slide. So this is NHS UK, National Health Service UK. This is certain guidelines, the 5 steps to mental well-being, how he should connect with others, how other people be physically active, new skills give to other. Next. Stop at this point. Okay, the theme of the conference is mental health is a universal human rights, right? So the rights is being stressed at every point of time. So go for a proper deliberation. I have divided my PowerPoints and discourse in 3 portions. First, the legislative portions, then the preventive part of the mental health, and the curative aspect of the mental health. Because if all of the things are in synchronicity, it goes pari passu, then we are going to have a comprehensive mental health care. That is what everybody is thinking about. Nowadays, we are thinking about comprehensive health. It's not that health should not be viewed as a separate entity. Everything should go hand in hand to have a holistic health status. So first, the burden on magnitude. About the theme of last year's World Mental Health Federation, they plan the mental health theme for every year. Last year, on the 10th of October 2023, the theme was mental health is universal human rights. I did attend a radio program from All India Radio, and we had several seminars and several symposium in our workplaces, and that was because I do look after the National Mental Health Program and DMHP, District Mental Health Program. It was spread all over the state. Different programs were there, just to spread awareness within the people and make people sensitized about the rights of the persons with mental illness. That is the thing that was being neglected so far. If you look at the international scenario, what do we see? That 10% of the people at any point of time, they are suffering from any kind of mental illness. That is the WHO World Health Report, and it's way back in 2001. And about this thing, I'm going to tell something, because lots of studies are coming out. I think the WHO will be, WHO will also be, I'll go to the next slide. Before that, what I mean, WHO will be giving an official certification or statement about the enhancement in the prevalence rate of any kind of mental disorders. In no time it will come out, I think, because it's a bit older statistics. Still it is there in the system. That's what 10%, it is the global scenario. At any point in time, that is the number of people who are suffering from any kind of mental disorders. Of course, there are certain subdivisions also there. Among these depressive disorder, I can see 1 in every 8 people. It's a very alarming statistics. 1 in every 8 people. That is 970 million total people around the world are living with a depressive disorder, with a mental disorder. And in the international scenario, what I see is that the anxiety disorder is much more predominant, which is a bit different from our statistics, because our National Mental Health Survey 2015-2016 that was conducted by NIMANS on behalf of Government of India, it was across the 12 states across India. They have got a little bit different statistics. In any case, I'll go to the next slide. This is the international depression alone accounts for a global prevalence of 3.8%. Of these, the female gender are suffering because depression is preponderant in the female genders. 6% they are suffering from this thing, and 4% people and the male, and overall prevalence is 3.8%. This is a WHO 2022 statistics. And about this global burden, you know the global burden of disease study that is going on since 1990. It's a World Bank funded study, and it's taking place in the Institute of Health Metrics and Evaluation at University of Washington, USA. So almost it is continuing, it's a multi-century study, it's going on all over the world, maybe more than 160 countries. What they do, they have got a new metrics for evaluation of different burden of the diseases. That is called DALY, Disability Adjusted Life Years. One DALY means it's a summation of YLL and YLD. That is years of life lost because of premature death and years of life lost due to disability. So that is the way they measure the different kinds of disease, not only mental illness, the other thing, cardiovascular, neurological disorders or GI disorders, all the diseases, I mean, not only diseases, some certain risk factors and injuries, they are also being taken into account. And that is what you see, previous slide please. That is what we see, that 15% of the total GBD is because of the MNS, mental, neurological, and substance use disorders. Next. Before that, COVID-19, you know all about COVID-19 pandemic. There is a massive enhancement, there is unfortunate enhancement in different, particularly mental health illnesses. COVID has seen loss of jobs, COVID has seen disability, there is a premature to unfortunate death of the only earning member in the family. Then the persistent, many of our colleagues, I mean the doctors and nurses, they have been disabled in the sense, few minutes of work are making them restless or without breath. So this is kind of disability that is what COVID has produced. So this disability, obviously, this is affecting there is a toll on the mental health illness, mental health also of these persons. So you can see COVID-19 pandemic, it has caused a massive increase in incidence of anxiety and depression, particularly anxiety. Anxiety, it has increased 26%. Overall, if you can see the disease burden, as per WHO, in the latest statistics of the WHO, anxiety disorders are much more predominant in the sense there are at present 300 million people suffering from anxiety, any kind of anxiety disorders. Could be generalized anxiety disorder, could be panic disorder, could be some other forms, could be obsessive compulsive. Though obsessive compulsive disorder is now in a different spectrum, still it causes a lot of anxiety. Then the depressive disorders come, almost 300 people come, suffering from anxiety, any kind of anxiety disorders, and 280 million people are suffering from depressive disorders. Out of 280 million, almost 23 million are children and adolescents. This is an alarming situation. Just look at it, the way, this is the magnitude or burden of the mental health problems that is in the global scenario. This is one meta-analysis study. This is the latest study that what I have seen is that this pooled lifetime prevalence of CMDs across 85 surveys, 29.2%. So previously I was saying it was 10%, now it is 29.2%, almost trebled. From 10 is almost 30. This is the point prevalence or of a lifetime prevalence of mental illness. Next. This is the Indian scenario. Indian scenario is a bit different. We are depending on the data of National Mental Health Survey 2015-2016. It was conducted by NIMHANS across 12 states in our country, and Kolkata was also, the state of West Bengal was also one of the participants. There we see Institute of Psychiatry. It was jointly done by the Department of Psychiatry and Department of Community Medicine and the Public Health section. And the results that has come out, still it is there in the different sites are there. So here you can see the overall prevalence of any kind of mental illness. That is lifetime prevalence 13.67%. And about the common mental morbidity, what are the common mental illnesses? Any major depressive disorder, mild and moderate severity, not the severe mental illnesses or severe depression or psychotic depression. Then come any anxiety spectrum disorders, and then obsessive compulsive disorders, substance use disorders. These are come under the purview of the common mental disorders. The lifetime prevalence is 12.3. And about of the common mental disorders, as per the NIMHANS survey, the lifetime prevalence of 5.6. What I can see, anxiety disorder is prevalent globally much more than depression. But in Indian scenario, depression is much more, almost 5.6%. Here, one thing, I wanted for this thing, product calculation. If I see at this point of time, our total population is 140 billions. So, 140 crores. So, if I see the current Indian population, almost 21 crores people are suffering from any kind of mental disorder. Of these, 17 crores are suffering from common mental disorders, and 2.9 to 3 crores are suffering from severe mental disorders. If I go for a head-to-head comparison with this burden, with this thing, and if we see our budgetary allocation, 0.05% of the total health budget is the allocation for the mental health, which should be more than 5%. That is what is happening in any developed country. So but there is budgetary inadequacy. And if you see the manpower, the total number of psychiatrists at present in India is around 9,000. If I go for the population ratio, it is 0.75 per 1 lakh population. This is the much more dispel in the case of this clinical psychologist, psychiatric social worker. This is 0.03 per 1 lakh population. Regarding the psychiatric nurses, it is 0.05 per 1 lakh population. What is my source of data? My source of data is from this Niemann survey, National Mental Health Survey. Then there is a technical committee report on mental health by the National Human Rights Commission. That is another. And the last is this membership directory of Indian Psychiatric Society, of which I am a life fellow of Indian Psychiatric Society. They have also got a membership directory. If I go for the pool data, the total number of psychiatrists at present around 9,000, plus maybe increasing, or many of them are working overseas, many of them are no more, whatever. So this is the scenario. At present, we need 42 to 45,000 psychiatrists. At present, this is the need. So there is a shortfall of 34,000. Regarding the psychiatric bed, we have nearly 56,400 psychiatric beds are there in India. There should be there is a need of 6.5 lakhs. This is the report of Delphi panel of WHO. So there is less than 15 beds per 1 lakh population. This is also an alarming scenario. So why I am saying these statistics, I am saying we can say that we have less manpower. We can see that we have much more less budgetary allocation. Next slide, please. So I have already covered it. Next slide, please. And coupled with that, there is a question of treatment gap. Huge number of patients, inadequate manpower, inadequate provision of psychiatric beds, and regarding the population, that is leading to the 75 to 90% mental treatment gap. Next. Niemann's, they are saying this overall treatment gap is 83% for any mental health problem. Next. So, with such a huge magnitude or load of mental disorders coupled with the massive treatment gap, it became necessary to promote mental health services. So, I have divided into three. First, the laws. Laws make us aware. Laws build up, laws propels the machinery, because that helps the government as well as the other NGOs, whoever working, to build up a lot of things, to fill in the gaps. So that is the needed, some laws are there. Then I'll go for some curative aspect and the preventive aspect of psychiatry. That will, I think that will fill the gamut of this accessible mental health care, something which we can access, which you can afford. Next. National health policy. Currently we have 2017, this is the law part. Initially it was formulated in 1983, then it came in 2002, then now the current national health policy 2017. They are speaking about the universal health coverage. Universal health coverage is something which means all citizens on earth, I mean all Indian citizens in our country, they should go for a free comprehensive primary health care. They should have the privilege, and this is irrespective of any bias. Maybe gender, maybe caste, maybe religion, maybe geographical location, maybe other situations, whatever. There should not be any discrimination. They should be able to access any kind of, that is what has been stressed by the government of India to the concept of universal health coverage. They are stressing on universal access to good quality health services. And the policy thrust is on mental health. Policy thrust on mental health. So I can see, I have tagged this thing with highlighted two particular points. One is manpower creation, and third is digital technology leveraging. this national telemental program or national telebanos, this is one of the one of the fallouts or the outcomes of this thrust in the digital technology leveraging. I'll come it later on. So, and thrust is also there because India is one of the countries we have a definite national mental health policy in the year 2014. So there are certain recommendations as well. So there should be a convergence with the the convergence between the national health policy and the national mental health policy also. Next. You can see we have a definite national mental health policy where there is, at the end point, you can see to ensure rights of mental ill persons. That is there. That was the theme of last year's World Mental Health Day. And that is that in our next. So you can see the evolution of the Mental Health Acts. Initially it was the Lunacy Act, then the Mental Health Act, now the Mental Health Care Act 2017. This is a way departure and improvement from the previous laws. In the present Mental Health Care Act 2017, afterward different states are formulating their own state mental health rules and mental health review boards. We can see that the rights of persons with mental illness, it has been stressed, it has been certified, and it is being tracked. That was, I am not saying it was absent previously, but now things are just moving ahead. I can see, and lots of things are also going on, lots of improvements also going on. We can perceive in our in our state also. Next. See, this act incorporates 16 chapters. Chapter 3 deals with unique advance directive. What is advance directive? Advance directive means any mentally ill person, provided he or she is otherwise mentally competent to take a decision on behalf of his or her treatment, they can give it in writing. They can give it in writing where they want to be treated, how they want to be treated, how long they want to be treated. They can give it in writing. This is an unique provision in the last Mental Health Care Act. That is the provision of advance directive. And in that portion, there are provisions of nominated representative also. They can nominate one person, maybe his or her relative, maybe caregiver, maybe somebody else with whom they are striking a right balance. They can take a decision on behalf of that person regarding the treatment decisions. They can do it. And this is called the nominated representative. Different chapters are dealing with the different provisions. And chapter 5 deals with the rights of person with mental ill. What are the rights? What are the rights? Anybody, any mentally ill persons, they can go to any government-funded mental hospitals, could be central government, could be UT, could be state government, and they have the rights to go for a free, accessible mental health care treatment. They can go for an independent admissions. Nowadays, all of the mental health admissions in any psychiatric hospitals are independent and voluntary, unless proved otherwise. It is by default, it is to be taken that the person is taking his or her own decision regarding admission in any state-run mental hospitals, maybe central government, maybe state government, and nobody is putting any pressure or any duress on that particular person. So this is a big departure from the previous ones. I have already mentioned about advance directive, and regarding the admission process, it is purely mentioned that they can take their own decision regarding admission. Okay, if there is a flare-up in that situation where the person is not being able to take the decision himself, then the nominated representative, as per the advance directive, they can go for the decisions, right? So this is a big, newer provision, a newer addendum that anybody can access mental health care. They can in any state-run mental hospitals. Next is right to information. They can get the information regarding their disease, regarding what is happening to them, how they are being treated in any hospital, how they are being treated, how long they will be there. All depends. Everything has to be in writing, and maybe the medical officer in charge of the establishment or the psychiatrist in charge, they are supposed to give the regular information to the patient or the caregiver or nominated representative, whatever. So this is another right to information. Then right to confidentiality. They have the rights. You cannot go and photograph them and spread their images and other documents in the social media. No, it's not possible. It is legally punishable. It is cognizable. It is not possible. They have the rights of confidentiality. They have the rights of good health. Because in a mental health care establishment, if the situation is untidy, unhygienic, and they are being restrained, or they are oppressed. It cannot happen. So that is also there. Different rights are being stressed in the, and there are other 10 others, the rights are also mentioned. So these rights has to be followed in totality, and this is being followed. That is a big, what I say, there is a big appreciation on the part of the psychiatric fraternity, and they are realizing it, and they are putting it in the actions also. And suicide or deliberate self has been decriminalized. Previously, somebody is committing suicide, or they are by the police, they were incriminated by the police and put into jail. This is not going to happen nowadays because it has been decriminalized. And next is health insurance facility. Mental health is being covered by the health insurance. So these are big departures. These are big additional advantages of the new act. This advanced directive, nominated representative, then the decriminalization of the suicide or deliberate self-harm, and the benefits of health insurance. Next. Then what are the international response? WHO Mental Health Gap Action Program. I have already mentioned 85 to 90% treatment gap is there. Why the treatment gap is there? Maybe because of lack of awareness about the mental illness on the part of the patients and their families. Maybe because of the stigma, fear of stigma and decriminalization. Few years back, I remember one thing, because we are in the board, in the certifying board for the elections. One big official from the Kolkata Municipal Development Authority came. They applied for the exemption from the election duty. What I said, so you are suffering from some depressive illness, something like that. I said, we can certify you, but we'll write it down in the papers because that is needed, because the returning officer of the election, he or she, whoever is there, they need that. He went out, consulted with the family and said, doctor, I don't need it. I don't need an exemption. It's better to go to an election duty than being certified by that you are having this mental illness, because that is going to be counterproductive in the official domain. So that is the stigma. So stigma is that people are not saying. Nowadays what you do, you go for the ICD-10 or 11 or DSM-5, whatever. We write the codes. At least that will help in the follow-up. That will help the other doctors also in the follow-up of those patients. Otherwise, if nothing is written in the treatment paper or treatment card, then it can lead to diagnostic confusion and the treatment confusion also. So that is the reason. It's a lack of awareness on the part of the patient, presence of stigma, and lack of awareness about the facility, about the availability of the mental health care facilities. What is there in our state? What is there in the central section, maybe in Bangalore, maybe in the Delhi? People are not aware. These are all leading to treatment gaps. So WHO, what they are saying, they are training the non-specialists, not the psychiatrists, not the psychiatric nurses. Next slide, please. Maybe general physicians, maybe general nurses, maybe community health workers. They are being, the care is provided by them, that is non-specialist care. That is going to reduce the treatment gap. Next. Why integrating mental health into non-specialized healthcare? That day I was addressing one training program of the doctors, that they are primary care physicians working in different primary, block primary and community health centers across our state. What I found, I found from certain study, one is the Cure 70 that happened in the Chennai Urban and Rural Epidemiological Survey, and one is Depression 2000 study, it happened in Germany. They are all saying that's almost 15 to 44% people who are reporting for any treatment, for any general healthcare establishment, they are having hardcore psychiatric diagnosis, psychiatric problems. So 15 to 45 to 46% diagnosis, patients are coming with vertigo, patients are coming with burning sensation of the different body, patients are coming with different kind of somatic features, but they're actually harboring depression. They're actually maybe some chronic maladjustment or some other issues which is being converted into physical symptoms. So you can see, and another alarming point is that primary care physicians, almost 30% diagnoses are being missed. They are being over-investigated. Lot of healthcare malutilization is there. So that is indirectly or directly that is leading to cost escalation on the part of our government, because this is taxpayers' money. If somebody is prescribed one MRI or one CT scan or lots of investigations, which of course we need it sometimes. We should be discretionary about that. But this is being largely misutilized because of the lack of awareness. That is the reason That is the reason. So we can see that there is a huge burden, there is low manpower, and mental and physical problems are interwoven. So this is the reason of non-specialized integration of mental health to non-specialized healthcare. And that can lead to enhancement of accessibility of mental health care. Right people will be screened and they will be given the proper treatment. Next. This is another WHO comprehensive mental health action plan. Initially it was started in 2013, extended in 2019, and they are extended up to 2030. Next. They are working in tandem with the SDGs. Initially, it was Millennium Development Goals. Now the Sustainable Development Goals are there, and mental health is one of the priority areas of the SDGs. So we can see, and regarding the leadership and governance, they are addressing the leadership and governance for mental health. That is very important, because if there is no proper leadership, that can go to a mess. If we don't have a good captain, the team is going to lose, in spite of the fact that several talented people are there in the team. So there is a need of proper governance. Next, there should be integrated responsive mental health and social health care services in the community setting, because we can see, I'll come later on, before inception of the National Mental Health Program, the Government of India in 1982, the Central Council of Health and Family Welfare, what they said is, let there be a shift from the custodial pattern to comprehensive mental health care pattern. Let there be an end to the mental hospitals. Because what mental hospitals do, they incarcerate those patients. There is an infringement or violation of the human rights. The patients are being delinked from their families. A lot of things are there. Productivity is being lost. Their dignity is being hampered. So that is the reason. And we can see nowadays, hello? Am I audible? Yeah. And nowadays, what you can see, no. Hello. Nowadays, what you can see is that these, there is in psychopharmacology, huge improvement and advancement in psychopharmacology. People are responding nicely, because this is science, and it will go on. Nobody can arrest science. Psychopharmacology is definitely progressing. And what it does is that the patient can be jolly well treated in the OPD setup, instead of being treating somebody. Okay, we can need sometimes we need institutional admissions and treatment like any other illness. Somebody who is suffering from acute myocardial infarction, he or she, yeah, somebody who is suffering from myocardial infarction, they cannot be treated on OPD basis, but they can be after recovery from the MI. Hello. Hello. After recovery, they can go for a OPD follow-up in the cardiology department. That is possible. So this is the reason that there should be a shift from the custodial pattern of treatment to the comprehensive pattern. So that is I'll come later on. So this was the comprehensive mental health action plan. Next. National Mental Health Program. Already I've told a little bit about the program. It was government had a meeting way back in 1980s, and the program started from 1982. The program, next please. This was the initial objectives. Provision of minimum mental health care to all, particularly the underprivileged. Then the community participation. What I mentioned, the patient can be treated in the community itself. There are 3 phases: identification, detection in the community, treatment in the community, and rehabilitation in the community. The role of the community and the family is very important over here. So instead of the institutional pattern, let us take the pressure off from the institutions, from the mental hospitals, from the maybe Department of Psychiatry or Medical. Of course, the people are free to come over here, but the team is coming to the patient instead of the patient coming to the facility. There is a bit of reversal. There is reversal of the approach. So promotion of the community participation and of enhanced human resources. Next. Already mentioned integration of mental health with primary health care. That is the thrust of the Ispn Bharat also. The comprehensive action plan, and mental health is, the people are getting mental health treatment facility as per the comprehensive primary health care plan. Provision of tertiary care institutions and All these things are there, eradicating stigmatization and the institution of different authorities. Next. What are the limit? But the National Mental Health Program failed. Failed in the sense it was not acting up to its reputation because of lack of awareness, or because lack of devotion on the part of the mental health professionals, particularly psychiatrists. They are not so much interested in this particular program because of the lack of awareness also. Then the emphasis was on the curative components and the preventive components. Role of support of the families were neglected, which is being stressed by the newer Mental Health Care Act. Family or caregivers or nominated representative, they have a role in the delivery of the mental health care services. Then the administrative structure was not clearly defined, and the budgetary inadequacy. Everything will fail for lack of money. That was there. Next. Then the DMHP, there was a famous Bellary model of Niemann's. The program was started in 4 districts in 4 states, Tamil Nadu, Karnataka, Andhra Pradesh, Tamil Nadu, Assam, and Rajasthan. 4 districts in 4 states were chosen. This was the famous Bellary model. It was a very successful model. And since 96-97, DMHP was started in a few districts. There was a plan to extend it in more than 100 districts across India. Now more than 90% of the districts across India is being covered by DMHP. In our state of West Bengal, I'm the consultant of National Mental Health Program also. We are having 28 districts, including the revenue district and the health district. In our state, there are certain health districts also because of the maybe administrative ease or convenience, they are divided it. And DMH, district mental health units, are there in all the districts. The program is running very well. Because as per the, we get the different activity reports by 10th of every month for the previous month. And what we see, what we have given as a routine to the DMHP team, I mean district mental health units, you should conduct at least 12 outreach programs across the district in covering every nook and corner of the district, and you should come down to the primary health center level. Then there are training provisions there, ASHA, or accredited social health activists, and the ANMs. They are being given regular training because they are acting as a liaison between the community and the health system. So they are also being trained about the basics of, there are certain guidelines are there, certain questionnaire are there. They are filling it up and they are sending to the teams. So they are also being trained to increase the number of patients. Next. This NMH was re-strategized in 2003 and later in 2009. In 2009, 2 big developments came. One is manpower developments came, and then is setting up of strengthening of PG training departments of mental health specialties. Under Scheme A, initially there were development of 11 centers of excellence in mental health across India. In our state, we have 2 centers of excellence. One is Institute of Psychiatry, and then the new development is the Calcutta Pavlov Hospital, Calcutta National Medical College. Next. DMHP, I have already mentioned what they do, how things will be recruited, and this thing, they are presently our state, I have already mentioned, this is we are fully functional DMHP served state. Next. Human resources, and there is particular 4 developments there. One is school mental health services, one is college counseling services, workplace stress management, and suicide prevention services. Next. Telemanush. Next. We can see that just because of the treatment gap, there is one, since our state is having 2 cells of Telemanush. One is sitting in Institute of Psychiatry, and one is sitting in there are 40 counselors are giving round-the-clock services about Tier 1. They are sitting in the Tier 1, basic mental health, basic counseling. And whenever anybody calls it 14416 number, we are trying to put, widely disseminate this number so that people can, this is an IVR-based helpline. And a lot of people are being aware, they are being sensitized about this through the media, different social media, television, and all these things. They are being sensitized. Okay, we are in the process of developing it, and our incoming calls are increasing. So Dr. Murugan, I have asked him to come and visit out this thing. 2 cells are there, 40 counselors are working. This is one of the reasons that because just to reduce the mental health gap, as already mentioned, 90% gap is there. Next. Curative mental services, next. We have the district hospitals. This is a general picture in our state also. OPD, 10-bedded IPD service. Medical college, 30-bedded IPD services. There is NIMHANS Bangalore. There is EVAS in New Delhi. There is CIP Ranchi. There is LGB IMS, Tejpur, Assam. We have 5 state-run mental hospitals in our state. We have 2 centers of excellence in our state in mental health. There are different private sector psychiatric facilities and ATFs. This is a newer development, addiction treatment facilities. Government India, in collaboration with the Social Welfare Department and the Health Department, they are going to establish 125 gap ATFs in the gap districts all over the country. Our state is going to have, already meetings are going on, 5 ATFs of addiction treatment facilities. This is for the drug de-addiction and rehabilitation. Next. Halfway homes in West Bengal, we have 2 halfway homes. Halfway because the long term, I have already mentioned of the rights issue. People cannot languish in the mental hospitals for lifelong just because they don't have any address or they don't have nowhere to go. Halfway home is something between the health facility and the home where the patient can be kept for some time and they are treated with some occupational skills. I mean, they are imparting some knowledge so that their social product, of course, they will be under treatment and their social productivity can increase. And for the old age people, after 60, we have also having liaison with the Social Welfare Department to, we have formulated some standard operating procedure also to put them in the Social Welfare Department homes. Next. Last, I'll just mention about the suicide situation. Just because we have conducted certain gatekeepers training program as per NIMHANS module, followed by this suicide intervention response inventory. It's a nice preventive module. Approximately, as per National Crime Records Bureau statistics, 1,64,033 total committed suicides in 21. This is largely preventive deaths. National suicide rate is this, almost 12 for 1 lakh, one of the highest in the world. And the highest is seen in 15 to 29 age, most productive age group. So this has to be prevented. And gatekeepers training program already we are having across the state. DMHP is participating over here. Next. Stigma should be taken care of. Next. So this is the last slide. You can see we should not stigmatize persons with mental illnesses. This is the last photograph of the National Mental Health Survey by the NIMHANS, where you can see people with mental disorders. They can be creative and productive with good care, caring society, and availability of opportunities. Next. Thank you.
Hall is open now, so if there is any doubts, please. Okay.
Failures. Why it's failing?
Good morning, sir. I have only one question regarding advance directive. Little clarification is necessary. When patient will do and what is the process?
Process is it's a legal document. The person who is in the right frame of the mind, I mean that maybe during the lucid interval, or maybe at that point, up to that point of time where he or she can give, they give his or own judgment. I mean, they know where they can have their treatment, what is their problem. Just because like other physical illness, we know that where we can have the choice. In case of advance directive also, it can be in writing. It can be in writing, and this particular advance directive, what I'm saying is that in that advance directive, the person can say how he can be treated, where he can be treated, how long he can be treated, and it is mentioned in the chapter 5.
Okay, sir,
Chapter
but my
3.
question is, so in the home, he can write? Only in
No.
he can write?
For that we have...
Where he will write?
Yeah.
Evidence, any witness is necessary like that?
The nominated representative will be there, the person's caregiver or the family will be there, and that application has to be there with the Mental Health Review Board, MHRB. Mental Health Review Board has to be there in every district or within a cluster of district. regarding that, they can be given the opportunity of writing the advance directive over there.
So he have to go to the mental health review board.
Yeah. Review board has they have the, what I say,
Witness.
they have the opportunity and they have the legal jurisdiction to get into any nitty-gritties of any advance directive regarding admission, regarding discharge, regarding supervision of these patients, particularly minors. Everything they can do.
Okay, sir. Thank you.
Yeah.
They can be updated on the failures of implementation of 2017 mental health. Because there are certain failures we are not able to apply fully, because still we are learning how to apply. 2017,
Yeah.
we are not able to apply fully.
What thing I'm seeing, madam, is that in the Mental Health Care Act 2017, there is provision of state mental health rules. We can see several states in India, they are yet to come out with state mental health rules. Many of them, they are yet to come out with formation of the state mental health authority, and also in mental review board also. If these supervising bodies, it is not properly built up, this is going to lead to this thing gap. I mean, there won't be any implementation. In spite of the fact that things are there in black and white, we are not going to put it in, action. Maybe, I don't know where is the bottleneck. As far as I know, as per the guidelines, from the inception and formulation of the act, within 9 months, I think, the state mental health rules should have been there. I can see regarding the rules in our state, it was 3 or 4 years back, right now, in 2019 itself, it was sent to New Delhi. Then it was sitting over there, then it was sent back, then the COVID was there for 2 years. You know the situation over COVID. Then it was sent back with certain, the objections and all. These are also clarified, and this was sent back, and there was some physical representation on our part also. Still, it has not come back.
I was part of the drafting in the initial stage.
Okay. Yeah.
So we know that it is not yet rectified. How should we do it?
This is the reason. I know that much I can say. There are some bottlenecks somewhere. This is the reason many states are lagging. Even for this telemental health program, we had a VC with MOH and FW, this national VC. All the states were participating. Many states are yet to come up with some concrete plans. Particularly, I heard about Manipur. Manipur is going, just because of the prevailing situation over there, they're going to have a burst of the patients. But they have not yet started telemanaged program. That is what we saw from the VC. Maybe these are the reasons, but we need more deliberation, and we should not lose the effort. That's
Gap also is not 100% given to everyone. Like
yeah,
some people are training, some people are not training.
yeah.
Like some of the psychiatrists are not at all using.
No. That is there. They are not aware. We need, what do we do to address that issue? We have told all the district mental health units to sensitize about there is one provision of the awareness campaigns. And we have told them, just because of the formation, because I had the shortage of time, I would have told in detail about the formation of the team in DMHP. The 4 mental health professionals are there, the program officer or psychiatrist, then the clinical psychologist, the psychiatric nurse is there, and the psychiatric social worker is there. They've told them just to sensitize people about the provision of the Mental Health Care Act, the medicos, paramedicos, and the non-medicos, maybe in the healthcare delivery facility, maybe in some other facility. They may be in the banks, maybe in the schools, maybe in the colleges. Let them be sensitized about the ability, the newer provision of the Mental Health Care Act. Because that is going to address the issue of the gap, treatment gap. Disease is increasing. Manpower is not increasing in that. It's not a directly proportional increase in the manpower. So what we have to do, we are stressing on the preventive strategies. Because if we go for the health education pattern and the public awareness pattern, or we can blunt that emergence of the risk factors, then definitely we are going to have some advantage in that front.
Any more doubt? If there is any other questions from audience? You have, okay.
Good morning, sir. I have one query about the advance directive. Sir,
Please, would you be louder, please?
oh, okay, sir. Sir, after selection of advanced directive, is it possible to change if a situation is old or
Yes,
if
yes,
I...
yes, yes. It is
Okay.
possible.
Okay,
It is
thank you.
possible. It is
How,
possible.
sir? How,
but
sir?
but
Sir,
that,
what-
that,
what-
that
what
should
is the
be
process?
that should be in cooperation with the Mental Health Review Board. It's
Oh.
a kind of quasi-judicial body because it is chaired by some retired judges.
Okay, thank you, sir.
Okay.
Thank you, sir. Please be.
Sir, thank you very much for such elaborative talk starting from 1948. I would like to read out the achievements of Dr. Samik Parnopal, State Consultant, National Mental Health Program, West Bengal. Okay. His talk was so elaborative, so scholarly, with all the statistics and all the salient features of Mental Health Care Act 2017. He is a senior specialist psychiatrist with the government of West Bengal, and his special areas of interest is adult and general psychiatry as well as neuropsychiatry. He has published several original articles in national indexed journals. Presently, he is associated with 2 leading research projects in psychological medicine at ICMR and NRS Medical College, Kolkata. He is a life fellow of Indian Psychiatric Society and Indian Medical Association. Thank you very much, sir. I would like to say a few things. How beautifully he narrated various developments in the mental health. When you look at a physical illness, there is a lot of sympathy, a lot of support. But when it comes to mental health, people consider it as deliberate behavior. So, when they consider it as deliberate behavior, there is, negative feelings in the minds of people. How do we remove that negative feeling? So, you should be able to get across to the public that it is not a deliberate behavior, it is a symptom of a disease of mental health. So in the disease, if you are able to get across to the public, that is, it's a symptom of a behavior, whatever. Once, we have put up a chair saying that if you ever felt sad, or if you have ever felt extremely happy, or never felt angry at somebody, you may sit in this chair. Is it possible for any human being? It is impossible. So these emotional aspects are considered negatively, and hence you should be able to educate people. This is a symptom of a disease, and please don't consider this as a deliberate behavior. One mother told me, before the disease, he was such an obedient son. He was such a lovely person. But once he gets this attack, he is totally different. So then I had to explain to the mother the way I have explained to you. Please don't take it to your heart. It can be treated, and it is treatable. So please, all of you as mental health professionals, get across this idea to the community. Number 2,
please don't feel that mental health aspects or psychiatric illness is compartmentalized. No. It is integral part of a human life. And you should be able to do justice to a human being to maintain both physical and mental health right from birth to death. So this is the message I would like to give to you as President of Indian Society of Psychiatric Nurses.
Thank you, madam, for beautifully. Thank you, madam, for beautifully chairing the session, and thank you, sir, for sharing your immense knowledge with our participants. Our participants have surely benefited from this session. Now I request Ridhamma madam to kindly present a token of gratitude to Dr. Paul. I request Ms. Kamala Khanal Upadhyay to be present here for assistance.
I'm delighted to receive these gifts from the very renowned dignitary, and that's from the Apex Mental Health Care Institution and Teaching and Research Institution, on the global, that is a global renown. So I'm privileged. Thank you, all of you.
Thank you, madam. Thank you, sir. The next session on human rights and mental health will be conducted by Dr. Ramachandra, former professor, Department of Nursing, NIMHANS, Bangalore. Sir will be present with us through a Skype session. Unfortunately, for some unavoidable reason, he is not present today physically. Kindly spare some time for technical arrangement for the online session.
Sir is there?
I would like to invite Dr. Sunita Sharma, Associate Professor, National Institute of Nursing Education, PGIMER, Chandigarh, as chairperson for this session. Madam is certified palliative care expert and has around 50 papers published in national and international journals. She has authored chapters in books of mental health nursing. She is a life member of Ispn India.
Okay, a very good morning to one and all present here. And good morning, Ma'am Ridhamma, Ma'am Sandhya. I have the privilege to introduce the next speaker. I think Dr. Samik has already said it all, and he's discussed about the human rights. So now the next speaker for this session is Dr. Ramachandran. He's a former professor, Department of Nursing, NIMHANS, Bangalore. And he's going to talk on human rights and mental health. And he is the proud recipient of National Florence Nightingale Award in 2016 as a mark of recognition for his meritorious service in nursing. And he has served as Principal College of Nursing, NIMHANS. Sir has been resource person for various conferences, workshops, and seminars, and has published many articles in national and international index journals. At present, he is one of the examiners for PhD examination, one of the resource persons for National Consortium for PhD, and he'll be present with us through a Skype session. Unfortunately, for some unavoidable reason, he's not present today physically. So he's going to talk on human rights and mental health.
Can I start now? Sir, we can hear you, sir.
Yes, sir, you are audible.
Please start. We can start, sir.
But mute your. You can start.
You can start present, sir. We can see your slides. You can start presenting, sir. Yes, sir. It's moving.
गुरवे सर्वलोकानां विषये भवरोगिणां विदये सर्वविद्यानां दक्षिणामूर्तये नमः. Very good morning to you all. And this particular session, I welcome you all for this particular session, which is on human rights and mental health. It gives me a great pleasure to participate in this particular August conference, where I used to be in all the places except few. One of them is this. I apologize for not personally being there. I request you to kindly oblige looking into this particular online presentation. I am highly obligated to the organizers who have given me an opportunity to be a part of this particular session, and I am grateful to Dr. T. Dilip Kumar ji and Dr. Redama and executive members of Ispn. I wish you a good day for you all. Now, human rights and mental health is a very important aspect. The human rights, as they are known today, have existed in India since ancient times. The principles related to human rights are laid down well in the Hindu religious texts such as Bhagavad Gita, Vedas, and Arthashastra. They also find mention in the principles of Buddhism and Jainism. Human rights belong to everyone regardless of nationality, sexuality, gender, race, religion, and age. Human rights are enshrined in human rights instruments. All WHO member states have ratified at least one international human rights treaty that includes the right to the highest attainable standards of health. After ratifying a treaty, the country has a legal obligation to protect and fulfill the rights recognized in that treaty. To deliver on binding human rights commitments, countries need to adopt a human rights-based approach to health. This is according to WHO, December 2023. Human rights principles would be on human rights-based approach requires mainstreaming of fundamental human rights principles and standards across the healthcare services and health systems policies, including public health, emergency preparation, and responses. They include non-discrimination and equality, and this requires prioritizing the needs of those furthest behind to achieve equity. Equity is used as a framework in public health to identify and address unfair and remediable health disparities among different subpopulations. HRBA provides legal standards and obligations to put legal protections for equality and non-discrimination into action. Participation requires empowering health service users, communities, and civil society to engage in planning, decision-making, and implementation process for health across the program cycle and at all levels of the system. To be meaningful, participation must include explicit strategies to address power imbalances, value experiential evidence, and manage conflicts of interest so that the needs and expectations of the people are met. Accountability. The countries must establish accessible and effective accountability mechanisms, and these may include administrative, judicial remedies, and oversight by other institutions such as national human rights institutions and health and social regulators. This also again with the WHO 2023. The core components would be the right to health includes four essential interrelated elements: availability, accessibility, acceptability, and quality. Now, the availability is the sufficient quantity of functioning health facilities, infrastructure, goods, services for all need to be there, like available of the material, like even simple material like, the bedpan, urine can, X-ray machine, and diagnostic measure, instruments or facilities, all those things need to be available. Accessibility is another important one. Whatever the thing has been spelled out, that those facilities need to be accessible to everyone. Persons with disabilities also, so usually they encounter barriers and need to be attended to. Then acceptability, then wherever we go, the people and the patients need to be accepted by the particular staff there. The medical ethics need to be followed, and even transgender also need to be accepted there. The quality, high quality care need to be attended to with providing the safe drinking water, avoiding injuries, and infrastructure need to be safe, and evidence-based services need to be given, and the reducing the waiting times and harmful delays also need to be amounted to, and the maximizing the benefits of the available resources and avoiding the waste also need to be there, providing the quality to the patient. In dignity and rights, they are endowed with reason and conscience and should act towards one another in spirit of brotherhood. The modern human rights have their foundation in the Universal Declaration of Human Rights adopted in 1948 by the United Nations General Assembly, and they have been integrated in national laws and international treaties over a period of time. Now, the basic human rights under UDHR would be around 30 articles are there. I'm not going to read exactly because it consumes time, and if you find time a little later also before we wind up, and I will read all those articles, but I will relate all those basic articles into the system of my speech. Articles which has been presented to, all the human rights are not being followed elsewhere. So in that particular context, what we need to do? Now, when we think about the human rights and mental health are playing a very important interrelated activities, so that the person's human rights need to be appreciated. Despite WHO initiatives to advance the major human rights to health, there is a need to look beyond WHO to address multi-sectorial efforts to implement human rights for public health across the entire UN system, where WHO continues to face obstacles to implementing human rights for health. It will be necessary to look into collaboration across international organizations to foster a global solidarity and bolster institutional efforts to mainstream human rights in addressing underlying determinants of health. Funding agencies incorporate human rights in international health assistance. Human rights agencies advance the right to health, and expanding efforts to mainstream human rights to health across the United Nations. Now, when we come to the mental health aspect as such, now historically we have seen mentally ill persons moved from asylums to sophisticated psychiatric centers with a newer evidence-based technique in the treatment. And that is for the people. Earlier, the misconceptions ruled the whole most of the time, and even the people thought that it is God is angry on them, and now it is a communicable disease and it spreads from one person to another person, and then we should not talk to that, we need not entertain that, people like that. Now, even in earlier days, when we look into the historical recordings, the people suffering from mental illness were being burnt in front of the public to see that evil should not enter into the public village or to a place. Later, one important person's family member got sick, and that person had thought thinking that an important member of the family should not be burnt in front of them, so they used to send it to woods, deep woods, forest, where the animals can take care of them. Later, another VIP's relative fell sick, mentally ill, and then he thought that why he should be food for the wild animals. He started a big asylum, like a big building built of stone and a big door with a big lock actually, and having a place where the food pellets can be given into the room, but without any other facilities available there. Now we can see sophisticated psychiatric centers are available with new evidence-based techniques of the treatment. Now here, when we come to this particular point, it is now at this juncture, what negative dimensions are there and what positive dimensions are there now available, how we can utilize the facilities for the benefit of the patients, we need to discuss. In this direction, now all these days, the treatment was given for the people. Now, when it comes to mental health, all countries are developing countries. No country has mental health care services worked out quite satisfactorily, according to WHO Director Shekhar Saxena in the Lancet 2018. Psychiatry has a legacy of coercion and deviancy, making seeking care, providing care, an alien activity with associated stigma. When we say associated stigma, it is extremely important to underline, because the stigma is now still playing a role. An important result of this perception of mental health being relevant to few unfortunate individuals has been main cause of stigma. For example, even nowadays also the stigma is playing an important role. For example, once so happened when domiciliary psychiatric nursing services introduced in NIMHANS during 1980s, one of my colleagues, Dr. Nagarajaya, along with Padma Shri holder awardee Dr. C.R. Chandrasekhar, visited a house to look after, talk to the mentally ill person in their house. But when they visited that particular house, the particular house had nearly 15 members in that particular big joint family, except this particular mentally ill person, all are doctors, medical doctors. And when they were chatting or discussing about this particular patient, and they gave a very good response that we are looking after the particular individual very well and a part of the family like that. And after having a cup of coffee, they were about to leave the house, and they heard a screaming sound. Where it is coming from in the house itself, and they wanted to see that door need to be opened. Out of resistance, they opened it, and they found the particular patient was there in a very bad condition, defecated there, unkempt, and then particular person was screaming a lot. Now see, now imagine the condition of a negative dimension here is, even in a medical family where all the members, nearly 14 members are medical doctors actually, father, mother, brothers or sisters, in-laws, and now how they have taken care of the individual in their home actually. Now we can imagine how the negative dimension has taken a role. This is a very important need to be taken care of. Now here, the human rights started with incarceration of mentally ill. Few unfortunate people, patients. Now it has moved on to mental health for all population. This is being a big change with a lot of implications for all the professionals and the people. Now, when we are telling about these things, sometimes we look at the positive dimensions also, which is being developed over a period of time, and also now still how the negative dimensions are taken care, especially through the stigma available now. Now, especially during COVID times, it has given us a new vistas as telling that how the people behaved very badly at their homes actually, and when we get a report, it is so sad to hear all those reports actually. Now here, Dr. B.N. Gangadhar, a recent review is done about the 4 decades of mental health care, summarizes the Indian situation as follows. First, let us see what the development has done and what are the factors that has made us to rethink to modify the mental health facilities available and what kind of services can be given, involving the public or the community. Now here, the recent developments in the mental health care scenario in India carry a potential for improving care across the country. Although preliminary, the recent developments can be considered promising as the number of patients now having access to the program appears substantial. With increasing use of the internet and mobile technology and sustained efforts and support from the policymakers, administrators, and academia, an increase in human resources is possible soon. Considering vast population of India, the wide prevalence of psychiatric disorders and a big treatment gap still prevails. These numbers, though minuscule, indicate a positive beginnings in the right direction. Now here, when we come to the evolutionary aspect which has been in NIMHANS and other mental hospitals, in a reflection, retired Professor R.S. Murthy narrated his experiments in the 4 decades aiming care mental ill through various activities like India has been a pioneer in public mental health during the last 50 years. And initiation of community mental health in 1975 is a very important milestone. And the launch of National Mental Health Program, which is extremely good and started doing very good activities around. And the disaster mental health initiatives after Bhopal disaster in 1984, and the district mental health program started in 1985. And then formulation of the mental health policy was there in 2014, another milestone. And then enactment of Mental Health Care Act in 2017 provided a newer direction with a lot of implications, legal implications are being noted down. And also reformulation of National Mental Health Program. And the most important thing is here, the expansion of training of human resources for mental health care annually from few dozen during 1970s to nearly 1,000 in 2023. Now the author convincingly suggests that the need for emotional health of total population and the feasibility of empowering the population for their mental health, the true public mental health approach. When we look after these things, during the last 2 decades, there is a revival of the understanding of the social factors and mental health. The review of mental health, the Lancet, WPA, Future Psychiatry, they mentioned it, a quote again, a large body of evidence shows the importance of social determinants for mental disorders, societal factors such as social inequality, crime, poverty, poor housing, and adverse upbringing conditions, and poor education, employment, and social isolations are related to and increase the rates of mental disorders. And this is again giving a different kind of, altogether a different feeling. Yet another comprehensive recent review, Kirkbride et al. Have highlighted the major social determinants that generate and sustain intergenerational inequalities in risk and maintenance of the mental health disorders. And this has given a newer direction to think that. And actually, there are so many things are being observed in these days where the poorer perceptions were being done. When we are looking into all these aspects, National Commission for Women in 2016 randomly selected 10 mental hospitals, looked into the possibilities, what they are being facilitated, what facilities they have been given, how they have been taken care of. Now, to their shock, actually, the facilities given to them were very poor, and then they were never taken care of well to the standard that has been spelled out. And then National Human Rights Commission in 2023, NIMHANS has done a health survey in 2014 and 16 and reported actually general population is 140 crore, and then 10% of that are suffering from mental illness, nearly 14 crores like that. And the severe infection or severe mental illnesses were there again 0.8% or 1%, nearly 1 crore of people are suffering from mental illness, but no treatment was accessible actually. That is a note, the note given by the NIMHANS report actually. When we are considering to the various aspects of these things, and again with the WHO report now here, transforming the mental health, the 2023 of APA, exploring the future of mental health, INSEL's book 2022, Healing Our Path from Mental Illness to Mental Health, the launch of 988 helpline crisis support of USA and Telemanas at NIMHANS in 2022, and the publication of the book, What You Did Not Know About Addiction by Kala AK in 2023, and the book Barriers to Recovery from Psychosis Generated Rethinking on Public Mental Health. So this has given a different kind of thinking, and with this background of the above facts, there is a need to think differently about mental health of the population, the public health approach of the people, by the people and for the people, and there is a sufficient evidence for promoting mental health and preventing mental disorders using individual, family, community and level of interventions. And when this is being there, and on completion of 200 years, publishing Lancet has also focused on number of mental health initiatives in 2023, last year. One of them is 5 ways to improve the mental health. In the table is given 5 ways to improve the mental health care for everyone and everywhere. End stigma, discrimination. We need to talk, listen about mental health, scale up the clinical services, protect mental health of healthcare providers, provide a fair and affordable access. That means here, the most important thing is then the stigma and discrimination, which is very, very difficult. And for that, during earlier years of 1980s itself, NIMHANS have made a lot of efforts to bring in a lot of important, significant professionals for the meeting, for discussion and giving an education or awareness program, including politicians, political people, lawmakers, and then policy makers, teachers, and significant others in the community, and they have been given an awareness and how this stigma need to be taken care of and how they need to participate in a community to see that this discrimination need to be taken out. A regular program was being done and that need to be continued elsewhere also. And then we need to talk and listen about the mental health. And whenever we speak about mental health, the people will be hesitating to tell the family members, if any family members are having any problem, that we need to encourage them to talk and listen about their experiences so that the intervention can be done more appropriately. Then scale up clinical services are very important. What does it mean, the scaling up means? The scaling up has been used to describe in an increase in the coverage of health interventions that have been tested in pilot studies or experimental projects in order to benefit more people and then support the policy and then provide a fair and affordable access need to be given to them. Now, the current situation can be addressed in following ways. There is a need to shift from the focus from the mental illness to wellness, the true public mental health approach. We have to aim towards making the mental health relevant and responsible for each and every member in the society and not limited to persons with illnesses. This is a very important one. The 4 actions are needed. Firstly, shifting focus purely from clinical care to public mental health, that is patients to population. Secondly, generating evidence for various psychosocial cultural, spiritual factors contributing the facilitating promotion of mental health, prevention of mental disorders, recovery from the disorders and self-care. Thirdly, networking with all stakeholders to address the social determinants for better mental health population, and such an approach has many benefits. And the advantages of this public mental health and focus on people would be increase in resources for mental health by many manifold, the stigma will be minimized, easy accessibility of care when needed, utilization of community strength and resources. Now, with this direction, a lot of thinking were there, and discussions were being held among the psychiatrists, what the conditions are there and how we need to address these activities. And when it is very difficult to provide all those things, all the facilities available elsewhere without any problem, and involving the family, involving the community, that is by the people, for the people and of the people, would give a impetus on how to take care of the individual is very important. Role of the family caregiver is extremely important concept, and that need to be taken into, and where Professor R.S. Murthy in discussion with various forum, he has brought out that in 1947 where 10,000 psychiatric bed was there, and at the same time 150 times more than India the Western countries also had. But Indian family members used to take care of their family members very well, and that is very important and to be looked into. So in India, what we call as Sambandha, Anubandha or Bandhavya are extremely important aspect where Indian family are looking into. But even now, when the psychiatric beds are increasing in number in India, but it's a minuscule when compared to the Western countries in number. Now the discussions are still on, even from 1960s onwards, 70s onwards, where the studies have been done in Sri Lanka, where the patients were looking better, where their expressed emotions were being less in particular area. And the studies were conducted in Vellore and other Amritsar also. The expressed emotions reported were very important the illness.
I think till the time they're fixing up, we can just sum up what sir has already talked till now. He has highlighted that the focus should be on wellness, from illness to wellness. It is extremely important that you focus on the wellness part of it rather than highlighting the illness, especially the mental illness. And if you talk about the identification, people need to made aware of identifying at the, we'll say the early stage, because the earlier the better, isn't it? And many people will discourage you for not getting your card made or showing in a psychiatric unit, because then they feel that you will be labeled as a mentally ill person. But it is not that you ignore things. Few things can go with counseling, but sometimes you need I will say, pharmacological intervention. So for that matter, you have to kind of see the psychiatrist. Everything cannot be done by just the counseling part of it. And for that, people need to be made aware of getting a card made does not label you as a mentally ill patient, isn't it? So encouraging about the public awareness and encouraging the family members to be cooperative and to kind of take the initiative of, if he needs help, he definitely needs help, and we all need to kind of, and if you talk about collaboration, it is very, very important that the stakeholders, the NGOs, the educationists, the healthcare professionals, all need to get together kind of to be aware of the rights of the individual, and he or she or me, we have full right to get ourselves treated for whatever illness we have. It is not that only physical illness needs to be focused. Mental health is extremely important. We all do understand as mental health professionals, and we should encourage people for that matter. So, sir had said that stigma also needs to be minimized. As I told you, that the stigma of getting yourself labeled as a psychiatric patient, that needs to be minimized. For that, we really need to have a lot of health campaigns and giving teachings and spreading awareness among the common people for kind of reducing the stigma of mental illness. Like any other illness, this is also one of the illness for which we need to focus and we really need to take care of, isn't it? Anyone else who would like to kind of add on or say something till the time? We are living in the digital world, so we have to kind of bear with it. Anybody else who would like to add on? So legal protection for the client is also very, very important, and taking the consent of the patient. Now, if we say it is very controversial whether the patient should get ECT, is he supposed to give the consent or the relatives can also do it? If we talk about the human rights, if he refuses for that, but it is indicated from the treatment point of view, so we have to give him kind of an option for deciding. If he cannot, then we can convince him for that, isn't it? You cannot leave the treatment because he says no. If the patient has no insight, so you can't look for a yes answer all the time, isn't it? So that is also very important. I think the session has expired and then they are going to reconnect for that.
Please bear with us for some times. One technical error is going on, please.
Recording in progress.
Sorry for the inconvenience. Please be seated. We are going to start now.
Now we can start now, sir.
Yeah, sir, it is audible. Sir, you can continue.
So can we start the meeting, sir? Can we do the presentation? Unmute. Listen, unmute it. So start from.
Yes, sir, we are. It is audible. You can continue, sir.
Yes, sir. Okay.
Audience, please be seated and bear with us.
Issues were there. So of course, now when we have seen the problems from a very long time till now, and negative dimensions were there, negative feelings or the stigma, and also positively, they have some with the positive dimensions, lot of improvements were there with evidence-based practices involving multidisciplinary team like psychiatric social work, psychology and psychiatric nursing, and the innovative measures research has been taken up. I will not take much time actually because time constraint will be there for the future speaker also. But most importantly, what we can do right now is most important. However, this has been long told by Dr. Kaplan that is primary prevention, secondary prevention, and tertiary prevention, and the negative values are there, moral values are being sinking down in the public and the community, and need to be addressed to one dimension. And the second one, with the popular approach that Dr. R. Srivasmurthy is focusing on, self-care activities need to be initiated in the community so that by the people, for the people, and of the people can be taken care of, along with the government initiative and the community, and it will be definitely being attended to with much more speed and accuracy will be there in taking care of the mentally ill person. So here, in the primary prevention, of course, is their aims at preventing the new arrest or one or more mental disorders of any other mental health issues. And this has been long told in earlier in Hindu times also, in Hinduism, where in Bhagavad Gita, where the pregnant woman is being told to follow some rules and regulations for having a good progeny. For example, hearing Purana Pravachanas and valor stories, good stories, and having eating a balanced diet, and her longings need to be fulfilled. So that this is called a Garbha Samskar. That need to be attended to so that they will get a good progeny line. For example, in Mahabharata, you have heard that Lord Krishna was narrating a story to his sister Subhadra about Chakravyuha. How to enter the Chakravyuha, he was narrating that particular story. And at that particular point of time, Subhadra went asleep. And looks, then he stops there. Now, after 16 years, without any formal education, Abhimanyu is to enter into Chakravyuha without any problem. He moved at ease, but he could not come out. And that hearing that particular story, when he was in womb itself, enter Chakravyuha at ease. And this has given a lot of impetus or conclusion to see that a pregnant woman need to be given a good directions, habits need to be modified so that the good progeny will get. Recently, about 1 month to 2 months back in Udupi, where Puttige Srimat was honoring a 3-year-old lady reciting the Bhagavad Gita without any problem, and she used to explain also in detail. And hearing so, and inquired the mother what she was doing during pregnant time. She used to recite Bhagavad Gita every day, and that has been possibly imparted to her progeny. So what now recent women are doing, pregnant women are doing, sitting late night in front of the TV, looking into crime watch. And they will be watching the crime watch, and they will be hearing horror stories and theft stories, murders issues, and how the progeny would be. It will be having a greater impact on the progeny also. In this direction, the pregnant women need to be taken care of, and then Garbha Samskar need to be there, and read the literature, religious one, listen to the soothing music, and go for walk and relaxation, very important, go for meditation, so that the progeny would be better enough to suit for mental health individuals. There are many stories actually, and records also are there in evidence to tell this particular impact of this Garbha Samskar and activities of a pregnant woman. Leaving aside this particular event, and Dr. R.S. Murthy is now focusing on involving the caregivers, family caregivers, and also community to take care of the mentally ill around surroundings. So the people need to be encouraged to practice the self-care, emotional health. He gives a very good examples and evidence as from earlier studies also, where studies were done in Sri Lanka, where Sambandha, Anubandha, Bandhavya played an important role in reducing the mental illness, and see that the person recovers very faster. Actually, earlier days we had 15,000 beds earlier. Now, although the 150 times more than the Indians psychiatric availability of the beds here, they did not recover in the Western countries, but the recovery was so good in India. And they're looking into the possibility how this has occurred, and the study was done by Dr. Left. Now, he is told that expressed emotions played a very important role. And expressed emotions like critical commenting, hostile comment, or over involvement has really blocked the recovery of the individual. But actually, instead, that in India, warmth was there. Expressed emotions were being limited, and they received the condition in warmth condition. Warming reception was there, acceptance was there, and positive regard was there, and the resilience was possible by self-care occupants. And I'm giving a few important activities that has been designed so that we can see that very simple remedial measures are there, like exercise, yoga, sleep, quality balanced food, or relaxation, social connectedness, journaling, music, the spirituality are playing a very important role like that. Now, one of the studies actually, many studies are being conducted, especially in Vellore and Amritsar, where the family involvement are taking care of. Value crisis was being there by caregiving a person expressed the challenges how to meet the value crisis. That also is very important, and a study was done at Singapore also regarding this particular activity, and that has been highlighted by Dr. R.S. Murthy also. Now, here the scoping skills and then the stigma, burden, uncertainty will definitely be taken care of by these particular care activities. For example, we need to hear with empathy. That's very important. Community also need to be proactive looking into the activities of that need to be taken care of an individual. And we need to hear what problems the people are having in taking care of the mentally ill person, so that we can be with them, so that they will get a moral support like that. Exercise, of course, one patient or one mother, she was telling to the doctor, telling that, I want to live longer, doctor, what shall I have to do? Now I have to take care of an individual, which is very important for me. I am having a daughter of now 16 years, 17 years, mentally retarded. Now after my death, what I have to do now? Now, for her safety purpose, now hysterectomy has been done. I cannot tolerate furthermore because God has given me this particular situation. Now we have to face this particular issue. And then very various issues were there, and now social connectedness were being brought in. And then he was telling exercise is very important, and daily at least 30 minutes of exercise need to be done. Daily, exercise need to be done for 30 minutes. Yoga therapy need to be given, so that exercise is very important to see at least will be at ease, face the situation, have a good sleep, and a quality balanced food is very important, and relaxation too is extremely important. And now social connectedness is very important whenever the person feels tired enough to look into the care of the patient. And also journaling, how the mental aspect can be taken care of, and listening to good music and soft music, whichever they like, and entering into spirituality. The spirituality, of course, that reduces the stress of an individual also, and the various activities need to be taken into consideration, because every aspect will take a long time to explain in detail every aspect of it. But along with these, involving the caretaker in the family, and also government also has to help in providing the money for them. For example, in earlier days, about 20-30 years back, in Nimans, in Karnataka, 50 years was given, 50 was given for mentally retarded or mentally disabled person. And where now in Pondicherry, now you see 3,000 rupees are given to that particular individual as a support system. And a health seeking UDID card also need to be done, and then entitlement of the need to be done. In Madhya Pradesh, this UDID card, they arrange usually camp, and the camp used to be there. And then they used to see that every activity being done, and then every UDID card used to be done, and then 5,000 rupees, and kit also is given to them. So like that, government can help. Also, the leave also can be given to individual. In California, if any mentally ill person is there in a family, the 2 months of full paid leave is also given to them. So in this direction, that also can be taken into consideration, that can be thought of like that. In Singapore also, the tax is also being taken out for the person who is having any family member in the group like that. So there are so many aspects are there. Along with that, involving the government. So we need to talk to the government persons through the medical member of parliament, advocacy and lobbying need to be done to achieve our objectives of taking care of the individuals. Now, institutional care, of course, it is there where severe mental illness is there. For example, nowadays, the depression and the so many suicidal activities are there, drug abuse, alcoholism is being noted down, and with this particular activities of the involving the total community is extremely important, so that it will take care of issues very meaningfully. Now here, when lot of discussions were there and can be discussed in different aspects with a different length of where negative dimensions also being attended to. So positively we can involve the people around, and then one suggestion was given that the government also can form the Indian Family Caregivers Act can be done, so that financial support and other support system also can be done in this direction, and the formulation of this particular Indian Family Caregivers Act definitely may be attended to, so that it will take into conclusion. Now, in conclusion, the promoting and protecting human rights is a complex and ongoing process. It requires cooperation between government, civil activity, civil society, international organization, and individuals to create a culture of respect and human dignity and equality. Now, even so, mental disorders need to be attended without stigma by people and of the people, and practice appropriate lifestyle. Lifestyle is very important to see that it can be attended to. Yukta ahara viharasya, yukta chestasya karmasu, yukta sapnava bodhasya yogo bhavis, and collective health approach should move from for the people to by the people and of the people. Social psychiatry has a vital role in this transformation of mental health. In this direction, now the professionals need to motivate the community and significant others in the community to be a part of this particular movement, and hence the society can be modified, and then they can discuss this particular mental health issues in different angle. Although now, for example, Deepa Padukone or Amir Khan could come out openly about their problems of depression and different behavioral issues openly. Why not? So it's very important to see them or having anxiety factors in a different way, then can be talked with the professional, and that can be taken into. In this direction, psychiatrists also telling a package for the community family caregivers. A class will be given as soon as the diagnosis is made on a particular individual, and 1 hour package program is being given on what exactly the illness means and how they can be taken care of, and what sources can be utilized, and how they can use all those particular activities at home, and then they can take care of an individual in a society. In this direction, if everybody cooperates for others and others cooperating for each other, definitely this movement will be more purposeful and meet the objectives more at ease, I suppose. In this direction, we need to think, and this newer direction, and definitely it will be successful in this direction. We should have a good day. Thank you very much.
Thank you, sir, for this enlightening session. It would have been great pleasure if we could meet you here personally. The hall is now open for discussion, and participants are being requested to please mention their name and the name of the institution before asking their queries.
They will talk something.
Any queries from any participant? Any query?
Okay, then if there are no queries, I think we are over with this session. And sir has highlighted the importance of human rights and mental health. And I think we need to focus more on the rehabilitative services. In many parts of the country, if we talk about North, the concept of like halfway homes or residential or the follow-up of the mentally ill is not, has not been taken up that much. And the concept of community psychiatry and making them aware and making a arrangement for the mentally ill, including the family caregivers, so that if it is a long-term illness or the patient has the illness for a long time and he is not hospitalized, so how much of care we can give him, supervised care, and he actually needs to live with the respect. And we really need to kind of make people aware and society at large to look and focus more on the rehabilitative services, which are, I think, are lacking behind. So thank you very much. And sir, thank you very much for highlighting the importance of human rights and the concern of human rights in mental health. Thanks a lot, and thank you very much, audience. And thank you, the organizers, for inviting me here for chairing this very interesting session. Thank you very much.
Thank you very
Thank
much.
you,
I am
madam.
highly obliged to the organizers who has given an opportunity. I sincerely thank Dr. T. Dilip Kumar and Madam Redama, Madam, for giving me an opportunity to be online presenting this particular topic, which is of great interest, and having a newer direction of involving the whole society in the care of the public, along with the newer concept. Of course, if severe mental diseases can be looked into by the psychiatrists and the available care in the psychiatric hospitals, and they need to take a consultation and counseling sessions with the concerned person if it is too much and cannot be handled in the family. Wish you good luck. Thank you very much.
Thank you, sir. Madam, please stay here. We are going to felicitate you. May I now request Ms. Madhurima Mondol and Ms. Payal Jana to felicitate Madam. Please give a huge round of applause for Madam for beautifully chairing the session and coordinating the whole thing. Nothing can be done from an empty cup, right? So let's refill ours with a 30-minute refreshing break. And we have e-poster presentation outside the hall. You can go over there. That will be coordinated by Mr. Anup Sharma, Deputy Nursing Superintendent, AIMS, Jodhpur. Please have the tea break and appreciate our surroundings. Tea, coffee and snacks are there. Please have it and come by 11:30 a.m. বলেছি পোস্টার প্রেজেন্টেশন হ্যাঁ বলেছি কোন the left and right side of the seminar room for having the snacks and coffee. Now let's welcome our next speaker, Dr. Lakshmi Nirisha P., Assistant Professor, Department of Psychiatry, AIIMS Raipur, to continue our journey of learning through the session on integration of mental health in primary healthcare nurses' role. I request Dr. Reena George, Madam, Head, Department of Psychiatric Nursing, Institute of Mental Health and Neurosciences, Kozhikode, Kerala, to take the stage and chair the session. It's my pleasure to introduce Dr. George, who apart from her HOD role, is a certified and licensed genetic counselor by the Board of Genetic Counseling, India. Madam has served as a member of the Board of Studies at Kerala University of Health Sciences and has been awarded the Distinguished Alumna Award 2021 from Father Muller College of Nursing, Mangalore. With over 2 decades of experience in the field of psychiatric nursing, she currently serves as a reviewer for many scientific journals. Please join me in giving a warm welcome to the exceptional and get ready to amp up your knowledge to the next level.
A warm good afternoon to one and all. Let me thank all the organizing committee members and I proudly present Dr. Lakshmi Nirisha for the next session on integrating mental health into primary health. So Dr. Lakshmi Nirisha is Assistant Professor in the Department of Psychiatry, AIIMS Raipur, to continue our journey of learning through the session of integration of mental health in primary healthcare nurses' role. Madam has served as Assistant Professor of Psychiatry in Department of Psychiatry, NIMHANS, Bangalore, and has been involved in teaching undergraduate and postgraduate students over the years. Madam has successfully spearheaded numerous initiatives in telepsychiatry at NIMHANS and currently working with National Mental Health Program workforce in capacity building for Telemanas, Chhattisgarh. Madam is a life fellow member of Indian Psychiatric Society. I proudly present Dr. Lakshmi Nirisha and inviting ma'am for continuing the session.
Thank you, ma'am. Thank you for the introduction. So, we've started a little late, so I think we'll begin if everybody is ready. So, today's topic of discussion is integration of mental health in primary healthcare nurses' role. So, this part of integration of mental health in primary healthcare. Actually.
Hello?
Sorry for that. So, beginning, we'll start with to understand what is the mental health scenario in our country. So, primarily, I'll be focusing on the aspects that is pertaining to our country with few anecdotes from what has been the experience in other countries. So, the National Mental Health Survey 2015-2016 said that noted that the prevalence of mental illness, excluding tobacco use disorders, in adult population that is more than 18 years was about 10%. And 13% of our population had some sort of mental illness at some point of their lives. And it has been noted that at least 1 in every 20 persons in India suffered from mental health issues. And the treatment gap in mental health was more than 80. That means 80% of individuals who had mental health issues did not access care, did not receive appropriate care. And this treatment gap, strangely, has been very huge for common mental health disorders. Though, as we know, it is very common, but still the treatment gap is very high. And also for substance use disorders for various reasons. And this burden is varying from rural to urban setting, which again becomes important for our topic today. Can you please? So common mental health disorders, including depression, anxiety disorders, and substance use disorders, have huge burden, as I've already discussed. And not just that, CMDs or common mental disorders have been linked to the causation and consequences of several other non-communicable diseases such as hypertension and diabetes. So hence, CMDs, which are usually the most ignored and neglected group of disorders, are often normalized as a part of routine life due to poor knowledge and attitude practices in the individuals in the community. 1.9% of the population suffered from SMD in their lifetime, and 0.8% of individuals had currently been affected with severe mental disorders as per the survey. And treatment gap for SMDs, despite the fact that they have severe symptoms which are quite obvious, the treatment gap was still quite as high as more than 70%. And these individuals also require long-term treatment and rehabilitation. SMDs are also associated with stigma and discrimination and often leads to further increasing the burden of SMDs in individuals, which Dr. Ramchandra also discussed in his previous session. Substance use disorders and such as alcohol use disorders, the treatment gap has been more than 85% and with a prevalence of around 4.6% of the population. Tobacco use disorders, the prevalence is still higher with 18.9% and the treatment gap is 91%. So what are the services that are existing in order to cater to these individuals? At present, we have mental health institutions which include INIs and other mental health hospitals that are there across the country, which are about 43 in number. We have general hospital psychiatric units in government hospitals, both central and state governments. Medical colleges, as we all know, NMC has this guideline that they need to have a department of psychiatry if they need recognition. So medical colleges also cater to the mental health services across the country. And lastly, but not the least, private hospitals and nursing clinics, which are also catered to the patients with mental illness. Coming to what are the government programs that are there for mental health. As we already know, the National Mental Health Program implemented in the year 1982, which was again revised to include DMHP in 1995, and further manpower development scheme, which included empowering or enhancing the manpower in INIs, medical colleges, district hospitals, which occurred in 2009. District Mental Health Program was implemented with the objective to enhance the coverage and accessibility of mental health care. And currently, on paper, it has been implemented in more than 700 districts across the country. Again, I would like to emphasize that the fact that this is on paper, many of the services may not be as expected in these districts as well. And these under DMHP, several district level activities are organized in district hospital setting and around the district hospitals. Under DMHP, let's see the manpower that's there. There are 8 exclusive mental health and non-mental health professionals that are included, which includes 1 psychiatrist, 1 clinical psychologist, 1 psychiatric social worker, 1 psychiatric nurse, community nurse, and then 1 evaluation officer and the assistant staff who work with the team. So district hospital is expected to cater outpatient services, assessment, provide counseling, provide psychosocial interventions such as getting assessments done, disability assessments, disability certification, along with inpatient treatment services, and lastly but not the least, to provide psychotropic drugs. At CHC level under DMHP, again outpatient services, counseling services, follow-up care, especially for people with SMDs, and medications, along with emergency services such as ambulance services to transfer to higher centers, IEC activities in the community, IEC activities along with several other collaborative activities such as school mental health program through the Rashtriya Kishore Swasthya Karyakram. Next slide. So why do we integrate mental health into primary health care? As we have seen that NMHP, subsequently DMHP, all have said that yes, we will have district mental health services, we have CHC services, but despite that, this integration has not happened. So why do we need to integrate mental health into primary health care? Can you please? So So usually, mostly what has happened is that mental health care is usually separated from other healthcare services. It is usually considered as a separate unit, or sometimes it is not even considered as a illness per se. However, until recently it was largely overlooked in primary healthcare, despite the fact that the WHO Alma Ata declaration way back in 1978 had said that it is important to integrate mental health care into primary health care. However, there has not been much progress until the recent years, that is in the last decade or so. The dearth of mental health professionals. As we all know, there are not as many as required mental health professionals in our country. Approximately there are about 10,000 psychiatrists. We again don't have the exact numbers, maybe less, maybe more. This also includes people who are staying back and working in the country, people who are moving out to other countries. Clinical psychologists, I was able to get the number for RCI registered, around 3,000 clinical psychologists. Approximately around 2,400 psychiatric nurses. This is again the numbers who are registered with the Indian Society of Psychiatric Nurses. And then approximately around 1,000 psychiatric social workers. And if we go back to the numbers that we discussed about how many people are actually suffering from mental health issues, this number is just a minuscule. Not just that, if at all we have to scale up or integrate, we have lack of trained healthcare providers in the community. There's a lot of knowledge gap, attitude issues in individuals who are working with other healthcare professionals, such as it could be general nurses, it could be professionals of other departments. Funding challenges. Until recently, mental health, in the health funding itself, there were a lot of issues. We did not get much funds. Medication procurement and supply. This is something that is not outrightly discussed, but procuring medications, supplying, having a regular supply of medications, not just in primary care settings, but also in district hospital and higher settings at times. Administrative challenges. I'm sure many of you have worked at some point of their lives, or at least some of you would have come in contact with administrative aspects when you're working in government settings. People have significant resistance. They'll be like, why do you need an extra person? Why do you need these resources? There is child care that is needed. A pediatric ICU is needed. A medical ICU, medical services, an extra OT. But the same thing when it comes to a psychiatric requirements, for example, extra beds, extra manpower, it is very difficult to convince the administrative or the policy makers. And challenges pertaining to the acceptance by the community itself. If you say somebody is depressed, somebody is anxious, most of the time it's either brushed under the carpet and said that, oh, nahi, this is nothing. Or it is usually trivialized saying ki, pagal ho, yeah, are you mad? You are not like that, or you are like this, not required. So a lot of times the community itself, we face a lot of challenges. So distribution of these services, we spoke about the whatever minimal services that we have. Can you please? There is discrepancy in the distribution of these services. We have about 900 million people living in the rural population, about 400 million people living in the urban population. So if we look at the services, maximum of the services are available in urban and suburban settings, whereas in rural settings, it's usually restricted to general hospital psychiatry units in district hospitals, where there are the set of people that we spoke, the manpower who may exist, may not exist at all times, and the secondary care facilities and the primary care facilities such as PHC. So let's come to the challenges per se. As to why we need to understand these challenges is because again we'll have to deal with these challenges to address the integration better. Demand side challenges, that is from the point of view of the receiver or the individuals in the community, there is significant stigma and discrimination. I think the more we talk, the more it is less. There is significant stigma still existing. Cultural beliefs in the communities, we prevent them from accessing care for mental health issues. Poor knowledge, availability, lack of services, infrastructure and human resources. If we have a person who is working in the farm for a daily wage of let's say 200 rupees, he goes to the farm. If at all he has to access a care, even at a district hospital setting, he has to spend his whole day in going and visiting a crowded district hospital and see if he can get a prescription for depression, anxiety, or for psychosis, he will not do that. So generally, availability and affordability play a big role in why people do not seek challenges. Accessibility, like I said, distance is definitely an issue. COVID-19. So all of us know COVID-19 has had a major impact in mental health care. It has rather brought into the focus of why mental health is important. So post COVID-19, it has definitely been seen in several studies that the prevalence of mental health issues has gone up in general population. During COVID-19 pandemic, definitely it came into obvious notice that there were significant challenges for people with pre-existing psychiatric illness in accessing care, both psychiatric and medical. It also brought into focus the need to address mental health of individuals along with physical health. So like we all know, there was the National Psychosocial Helpline, which almost started very beginning of the COVID-19 pandemic, probably even before the actual lockdown was announced. The services had become available pan-India, which showed that why it is important to address the mental health of individuals. Again, Mental Health Care Act. Like Dr. Ramchandra sir also pointed out that Mental Health Care Act has definitely brought a lot of legal mandate. Policymakers had to take a note of mental health and make sure that the services are available. It demonstrates that there is right to access to government-sponsored care. So actually it states that if care is not available within the community of the individual, he can actually ask for sponsorship or for monetary request in order to seek help elsewhere. It emphasized again the integration of mental health into general health care, entitled for reimbursement like I've already mentioned, and that essential drug list. So medications have to be available in all CHCs, that is community health centers and upwards. And it showed that it also has stated that within 10 years, the human resources are also needs to be improved. So what are the advantages of the integration? One is that accessibility. There are more than 3 lakh primary healthcare facilities ranging from PHC to Ayush Arogya Mandirs, which was the newer term for health and wellness centers, and which are functional across the country. It is affordable and cost effective. Individual need not travel. He can go to his PHC or the CHC or health and wellness center to seek help. And accessibility by the community is better. If somebody need not travel, they are getting help close to their place of residence, then it's likely to be more accessible to, and generating better health outcomes. As medical professionals, as healthcare professionals, mental health professionals, what we ultimately want is a good outcome in the patient. So task shifting, which is where the integration comes into play, by healthcare providers has demonstrated that depending on the training, roles and responsibilities can be defined, and specific tasks can be given to the healthcare providers and ensure the care is provided. It enables early screening and identification of individuals with mental health issues. Continuity of care is ensured. We know even if it's depression, common mental health disorders, substance use disorders or severe mental disorders, the care is going to be long, follow-ups are required and medications need to be continued. Monitoring and psychoeducation will be happening more closely when it happens, when the services are provided within the community. And care at doorsteps whenever feasible. This is something that is largely being explored recently, wherein ASHA workers, CHOs, nurses are also being employed if wherever feasible, where the medications, where the assessments and other evaluations are carried out at the individual's home itself. And last but not the least, prevention and promotion activities can happen more frequently and on a continuous basis. So now coming to the most important aspect that we all have come here together is to understand what is a nurse's role. So first let's come to understand as to what is the role of a primary care nurse or a general nurse working in other healthcare settings. So what is the position of nurses in the primary care? Nurses overall constitute more than 30% of the total workforce. Majority of them are usually the first point of contact. So whenever we visit a PHC or if a patient visits a hospital, the first person that he or she comes in contact after doing the registration formalities is a nurse, who is either going to check the blood pressure, weight, whatever it is, the first point of contact is going to be with the nurse. Nurses, if trained, are in a position to provide care for majority of the medical issues. and a primary care nurse who's likely to be in more proximity within the community, it makes them more acceptable. It's usually most likely the nurse would be somebody from the community itself, so people are more likely to accept their advice and listen to them more with care. Also, sensitivity to cultural needs. So somebody coming from a different place going into the community, sometimes the acceptability may be difficult. Also, they might not understand the cultural aspects of the community. So primary care nurse who's from the community itself can be more sensitive to the cultural needs. And more recently designed cadre, that is the community health officer, have been designated to provide comprehensive health care, which includes mental health as well. Nurses also form an important linkage system between community health workers and the healthcare settings such as PHCs, CHCs and Ispn Arogya Mandirs. So what kind of care can a primary care nurse provide in the community? So first but most important is the screening, which could happen in the community or in the primary care setting. The nurse is in a capacity to come in regular contact with the CHW, so hence she can keep talking, she or he can keep talking to the community health workers and identify people with mental health issues. Early identification leads to early diagnosis, and the nurse can counsel the person to seek help. Referral to a physician or a specialist, collaborate with the general physician who's there, or a primary care doctor who's there within the healthcare setting in the PHC or the CHC, or whenever required, make appropriate referral to a specialist such as a psychiatrist. Continuity of care. Once, let's say somebody has been diagnosed with a mental health issue, continuity of care, the nurse can ensure that the medications compliance are ensured. They can dispense medications whenever there are medications, what medications, when to take, the nurse can dispense the medications, and care at doorsteps like we've already discussed. Most importantly, promotion and prevention activities, community awareness activities, and collaborating with other community stakeholders such as the panchayat or the people in the community itself. How to achieve this? So again, the hurdles that are existing and are likely to be a problem are most of the nurses are not adequately trained in mental health. Definitely BSc courses, which are longer courses, have mental health, have psychiatry postings, they are exposed to psychiatric illness. However, the training may not be standardized, the training may not be present everywhere and for all courses that are there. So hence, they have not come into the workforce with adequate training in mental health. Poor knowledge, attitudes and practices within themselves. A lot of times in my experience, in our experience, we've seen is people themselves to trivialize. So recently, we were just interacting with a nurse for some other reason. The first thing she said was, okay, you are psychiatrist, so you read the mind. आपको पता चल जाता है, आप दिमाग पढ़ लेते हो. So she was a nurse who was working in a big tertiary care center for many years. But it does show that people themselves have poor knowledge, attitude, practices. Pre-existing negative perceptions regarding mental health, stigma and fear are again very big important issue, because if they are worried about how people will react to them, there's already existing stigma. The fear itself can impair the nurse's ability to deal with mental health issues in the community. And last but not the least, limited participation in making treatment decisions. Most often, as we all know, the nurse is generally not included in the decision making. So this is something that prevents them from taking up more newer roles. So how can a primary care nurse provide service delivery? Ultimately, we want the service to be delivered. Again, important thing is the training, like we have discussed the issues with that, mentoring and monitoring. So what is the target of training? We need a curated training curriculum for in-service primary care nurses, thus empowering them to address mental health issues in the community. We cannot expect them to know everything from A to Z about psychiatry. Definitely, whenever we are addressing training needs of a primary care nurse or a general nurse, that should not be the target. Focused group set of disorders, focus group of symptoms, at least identification should be done. So curated training curriculum is important. The training should be pragmatic and practical. The nurse is not going to do CBT, or she's not going to monitor somebody with treatment-resistant depression or treatment-resistant OCD. So it needs to be practical and pragmatic. And training should cater to enabling screening for presence of mental health issues. Perform basic non-pharmacological interventions. So it has been seen that nurses are in a capacity to provide, basic motivational interviewing for individuals with substance use disorders. So basic non-pharmacological interventions they can carry out. Provide referral guidelines, know when to refer, when not to refer a patient. Carry out mental health awareness and promotion activities, and to provide continuous professional development. So whenever we are targeting training, always the person who is getting trained also looks at what is there for me. So definitely certificate courses, giving them incentives, all of this also become very important while we are training individuals. So what are the existing training materials that have been formulated over the years? The MHCAP treatment guide, intervention guide in community health by the WHO. There is again another mental health and psychosocial support minimum service package which is done in collaboration with Sangat and another group of WHO group of international this thing. And disorder specific training. So most of the times we see that NGOs and certain groups come up with training programs, come up with intervention modules and plans targeting specific populations such as perinatal mental health and child and adolescent mental health. However, these are usually vast, they are not comprehensive, and generally the retention is poor. That is the training retention, the knowledge that they acquire, usually it gets disintegrated within few months or years once they've lost contact with the trainers. So currently in India, right now for primary care nurses such as the community health officers, there is the training manual, that is MNS care, disorders care for community health officers at Ispn Bharat Health and Wellness Centers. I'm sure many of my seniors here have worked on this manual. Again, more recently, one more manual schedule that has been designed is a clinical schedule for primary care psychiatric nursing, which is a validated schedule for primary care nurses in lines with similar schedule that is there for primary care doctors. So this CSP manual for doctors was designed basically, again, like I said, to, curated for certain specific disorders and to provide specific interventions. In lines with that, the CSPN was designed recently. Yeah. So capacity building initiatives and the training initiatives, cadre specific training for CHOs are being carried out all across the country as a part of Ayushman Bharat training and also as part of NMHP training activities. INS such as NIMANS have been conducting several certificate and short-term diploma courses for nurses. They are mostly digitally driven, diploma in community mental health for nurses. There are several other short-term and long-term certificate programs that are being conducted, and eco programs by institutes such as NIMANS and other digital academies across the country. So you will be listening to more of these innovations about digital training programs tomorrow. Yeah. So again, the service delivery, how it happens, screening and identification, case management, coordination, patient education, systematic follow-up, psychosocial interventions, and shared decision making with patients. So what are the various models? Just want to appraise you about the various models of delivering mental health in primary care have been seen over the years and in different countries. First is the coordinated care, which includes basically a nurse or a primary care worker refers a patient to a mental health professional. Second is a co-located care wherein the mental health professionals or a mental health facility is available within the primary care setting. Usually a nurse has to just refer the patient from one room across to the other room. Integrated and collaborative model, which are mostly synonymous to each other, is where the nurse and MHP sit together, see the patient in the same setting, and collaborative care is where the primary healthcare provider, who can be a medical or a non-medical worker, work in collaboration with specialists. So coordinated care, a quick example, nurses screens the patient, identify presence of mental illness, refers the patient to a DMHP or a mental health institute. Her work stops here. So beyond this, the nurse may or may not follow up. Next slide please. Coordinated care, nurses screens the patient, identify presence of symptoms. Next. So integrated care, nurses screen the individual, identify presence of symptoms of mental illness, refers the patient to the general physician who may be trained in mental health or the mental health professional, wherein both of them sit down together and come up with a care plan. Follow-up care is done, which could be in person or via telemedicine such as in eSanjeevani and through Telemanas portal. So here the nurse is able to provide initial care, follow-up care and also take care of other aspects, non-pharmacological aspects such as providing basic counseling. So collaborative care model is basically an evidence-based service delivery model in healthcare, and its benefits have been demonstrated in several studies both in developed and lower middle income countries. It basically employs a pragmatic strategy to deliver mental health care and general medical care in primary setting. So basically it works in a way where the patient has diabetes, patient has hypertension, patient has depression. So both of it are taken care of together without the patient having to move from one setting to other setting or from one specialist to the other specialist. Here the collaboration is between the mental health providers and primary care healthcare providers such as nurse, who employs coordination with the specialist and utilizes community resources as and when needed, also outside the community when required. So now coming to where is the role of a psychiatric nurse. So all of you are psychiatric nurses, you're specialist nurses. So what is your role in primary care? So DMHP, as we have already discussed, it actually has a psychiatric nurse in the workforce. However, we definitely know that the numbers are very minimal. There's usually a lot of times the workforce is dynamic. Nobody generally retains themselves in these posts for a long time. Their responsibilities basically include to examine and manage healthcare needs of mentally ill, to provide inpatient care wherever there is an inpatient care facility, to do outreach activity and plan and management psychiatric clinics at PHCs and CHCs, and to impart training to health personnel for CHC and PSC as per guidelines. However, their services are not utilized fully in the community, and most are usually restricted to hospital and teaching facilities such as nursing colleges. So psychiatric nurse, most important role would be in training, and other important aspect of service delivery that we have already discussed is the mentoring and monitoring part. A psychiatric nurse plays a very important role in these aspects. So psychiatric nurse is in a position to provide continuous mentoring to primary healthcare providers, both nurses and other providers such as community health workers. They can partake in collaborative care. They can also be part of the team. The psychiatric nurse can impart decision making and patient care advice. Taking up of leadership roles as to how to carry out a service, how to design a new service, instill confidence in the primary healthcare workers such as a nurse, and reach out to them as and when need arises, and to provide best possible care. Mentoring also ensures continuity of cares and enhancing skill. Most of the times a one-time training has been seen that it does not help in retaining the skills or the knowledge they have acquired. So continuous mentoring will also ensure the retention occurs and their skills are not lost. And in this, technology has played a very vital role in this process, such as in telepsychiatry driven training programs. Monitoring also becomes an important aspect, or where the psychiatric nurse needs to be involved. Monitoring of services in primary care to ensure service delivery is occurring. Quality control, definitely we don't want subpar services being provided, or quality is not maintained, patient is not provided adequate counseling, or there is violation of rights of individuals. Identify deficits and adopt corrective measures. The psychiatric nurse should be able to identify these deficits and ensure corrective measures are taken either through training or through administrative changes. And through collaboration with other mental health professionals such as psychiatrists, social work, and psychologists in the community, psychiatric nurses can also address policy making and administrative hurdles. So I'll just give you a quick case scenario to just see how this whole aspect of integration works. So this is actually an experience that we have seen over the many years that I've worked in primary care psychiatry and telepsychiatry. So this is about a young general nurse. She's basically a nurse who was working in a district hospital setting, who had undergone a short-term training program in mental health from NIMANS a few months back. She reached out to her trainer basically through WhatsApp. She said that she wants to know what to do about a person in her village. So the telepsychiatrist then discussed the details of the individual symptoms. She also reported that patient has significant aggression and was unmanageable at home. She reported that patient was earlier treated in Ranchi, but again he was not able to access any medications, or he could not go for a follow-up because of COVID-19 pandemic. So this was just around the time when the first wave of COVID-19 pandemic and the lockdown was very strictly enforced. So what did the nurse do? nurse then connected with the primary care doctor through the means of telepsychiatrist. Telepsychiatrist basically gave the contact details of the PCD, who was also undergoing training and was working in the district hospital. So PCD evaluated the patient, discussed with the telepsychiatrist how to handle acute aggression. As we all know, aggression means patient warrants, higher center referral, and probably IP care. Medication was initiated in the tertiary care center and patient was referred out. Patient was basically asked to come on outpatient basis. Subsequently, what the positive things that happened was the nurse was actually able to monitor the patient despite the fact that this patient was not in inpatient care. She was able to provide follow-up. She was communicating with the PCD because she was within the community. She knew this person, she knew where he stayed, and ensured that the medications are being administered. Post 3 months, again we have a challenge here. The PCD got transferred. So there is a new general physician who comes in who probably is not trained, doesn't know anything about the case, but the nurse was able to follow up with the telepsychiatrist. She was able to titrate the doses in relation to his side effects and the level of improvement. Ultimately, patient was continued on medication and he was able to get back at work. So this is just one such scenario that I've explained. We have had many such positive experiences wherein individuals in PHCs, in remote villages have been treated, have been referred to higher centers by the PCD, and sometimes we have had cases where the nurse is not even able to send the patient to a GP. So usually it's the psychiatric nurse sitting in Nimans, via telemedicine. She's seeing the patient, then discussing with the psychiatrist there, and even sometimes we've given prescriptions without even the person visiting a primary care doctor. So this shows how technology can be harnessed and how technology can help a nurse treat a patient in a remote village also. So next, in continuation with the fact of technology that I'm focusing on is the telemanas. So again, like I said, COVID-19 pandemic brought into focus that mental health is important. So subsequently, government took a note, the interventions that were being done, the kind of drive that mental health specialists were taking up more important roles in enforcing psychosocial support being provided across the country. More recently, the National Telemental Health Program came into force. So basically, this is an offshoot of National Mental Health Program as a part of DMHP. The Telemanas was initiated. So basically, it aims to provide universal access to equitable, accessible, affordable, and quality mental health care 24/7 through telemental health counseling. Its objectives are to basically scale up and reach mental health services to all individuals across the country, to implement full-fledged mental health service network, and to extend services to vulnerable groups of the population and difficult to reach population. So Tier 1 and Tier 2 workforce, the Telemanas works in 2 tiers, wherein we have a range of mental health professionals ranging from basic counselors to a psychiatrist who's sitting either at a district hospital setting or is sitting at the mentoring institute or a specialty center. So Telemanas aims to provide the comprehensive and collaborative mental health care that we've been discussing now. And here both primary care in the community, community nurse and the psychiatric nurse form an important workforce. So the program framework allows for obtaining maximum utilization of primary healthcare providers, where the primary healthcare provider, either a nurse, a community health worker, or an ASHA, can reach out to mental health specialists such as a psychiatric nurse who's either stationed at a Tier 1 facility, that is a mental health state cell, or at the mentoring institute or a tertiary care center. So last but not the least, the most important aspect as specialists, as mental health specialists, that would be important is to carry out research. So mental health research, as you all know, it is a part of your psychiatric training during course of your master's, and continuing research activities after coming out, after obtaining the degree, especially in public health research, is actually quite vital and important. And this is something, public health research is something that is not usually taken up, considering that there's a lot of hurdles involved, but actually it is one of the most important area of research that one can take up. So there are many training programs like we have discussed. We have a lot of things happening across the country. However, there is significant dearth in what is the actual impact or the patient outcome measures. So hence, this is something way forward. We need to look at how research can be done in aspects of nurse-led interventions, or to look at what other aspects of nursing care can be improved in mental health care, especially at the primary care level. Moving forward, there has been some discussions like in other countries about nurse practitioner, whether a general nurse or a psychiatric nurse themselves carry out interventions including prescription. As we all know, prescription rights is something that currently is restricted to only doctors. However, they are looking at this aspect where a nurse practitioner can take up the role of initial prescription of medication, wherein the patient need not wait to go to a hospital setting to meet a doctor. So what are the challenges? Definitely this is not going to be restricted to smooth movement. There will be challenges. Important thing is difficulty in recruitment. So there are challenges in enhancing manpower existing and to get new manpower. So recruitment is something that's challenging. Attrition in manpower is also something that's very important, especially in psychiatric nursing or in nursing care in general. We have seen definitely a lot of psychiatric nurses, they either move out because they are not getting more out of the country, because they are actually not getting the kind of job satisfaction or the job roles that they are actually hoping to get. Pay disparity, this is something that cannot be overlooked. Definitely healthcare providers are underpaid, and nursing general nurses and subsequently higher mental health specialists are also not paid adequately. So this pay disparity is something that definitely causes or demotivates people from taking up more of such roles in the government setup. Uncooperating administration, so administrative challenges are significant. So when we were training general nurses in district hospital setting and some from PHCs, they would often come back and say, ma'am, today I was supposed to sit in the OPD and see patients or screen patients, or I had to take up this tele training with you, but they told me no, you are not required there. Wo zarurat nahi hai, you go to the OT or you go to the emergency. So generally they are not allowed to take up these roles because, again, like I said, administration does not consider mental health as an important aspect. And most importantly, there is limited representation of nursing faculty in policy making and public health research. So these are the few set of challenges. Definitely, I think all of you, if we sit and introspect, there will be more such issues that we can come up. In conclusion, I would like to say that capacity building and collaboration are the keys to integrating mental health into primary care, with nurses being an integral part of the process, both general and specialist nurses such as you all psychiatric nurses. Thank you.
Thank you, Dr. Lakshmi Niresha, for a wonderful session. We could see a dedicated psychiatrist above all the topic content. You have started from the scientific data of gap between the surveys available treatment and till the challenges and what else we have to do. It's an eye-opener for everyone who are sitting here. What training we have to give to our general nurses to be trained and to recognize, and above all, they should have assertiveness to diagnose, screen and refer and be a policy maker. So that also you have told what hurdles we have to cross. And now the floor is open for discussion. If anyone have, okay, since we are running short of time, please, we limit the questions to 1 or 2 people. Maximum 2 persons can ask anything other than Madam has presented. If it was already included, please don't ask. Sorry. Anyone?
Participants are being requested to clarify their queries, if any.
Someone is standing there. Can you please give the mic?
Please raise your hand if you have any query. Thank you, madam, for this nice session.
There is one question.
Okay.
Yeah, please, please.
Hello.
Thank you. Madam, can you focus on can we develop any tracking and monitoring system with the existing health force which are there at the primary care level, particularly for the patient who are chronically ill?
So
Chronic mental illness, I mean to say.
definitely, I think this is a very important question you've asked, ma'am. So, tracking aspect and monitoring patients is something that's being developed. So, there are a lot of mechanisms that are being coming up as a part of MHCA. The mental health institutes have to be registered, and there would be a registry as a part of MHCA and registration where the patients also will be tracked. And Telemanas, under its realm, one of its aspects is ensuring monitoring. So the whole aspect of NMHP, DMHP, all the patients who are reaching out to Telemanas, subsequently what happens to them, the follow-up aspects, everything are something that's work in development. I will not say that this is already happening, but this is something that's the future goals of Telemanas, which is basically a part of NMHP itself. And some states already have some tracking mechanisms which are there locally, this thing, but national level tracking mechanism is something that's being planned.
Anyone else? Now I request Madam Reena George, please felicitate Dr. Lakshmi Nirisha P. I request Ms. Sakshi Gogoi and Ms. Payal Jana to kindly assist Madam. Please give a huge round of applause. Madam George, please stay there. We will felicitate you too. I request Ms. Sakshi Gogoi and Payal Jana again to felicitate Madam George for chairing the session.
Thank you, ma'am. Now we move on to the fourth session, and for this we have been very fortunate to have Dr. Bula Bhadro, Professor Emeritus and Director, Center for Interdisciplinary Studies and Research in Social Sciences of Sister Nivedita University. Madam will be speaking on community living and mental health promotion. This session will be chaired by Dr. Sandhya Gupta, health consultant and lifestyle coach, former acting principal, College of Nursing, AIMS, New Delhi. Madam has been the chairperson of nationwide training for capacity building during COVID-19 and is the member of expert group on mental health training, WHO Geneva. Besides her numerous achievements in the academic field, she has achieved Best Research Award of Amazonians of America and published over 159 publications in scientific journals, modules, and books for WHO and Ministry of Health and Family Welfare.
So now let's begin another session of knowledge and innovation. Madam, kindly take over.
Thank you very much, organizers, for inviting me to chair the session. I'm fortunate to introduce Dr. Bula Bhadra, Professor Emeritus and Director, Center for Interdisciplinary Studies and Research in Social Sciences in Sister Nivedita University. She has been working for very, very long time, 28 years teaching in the Department of Sociology at Calcutta University and at many national and international universities. She is going to talk about community living and mental health promotion. She is a recipient of Professor D.N. Majumdar Memorial Gold Medal as Distinguished Social Scientist by Indian Social Science Association 2017. Most significantly, Dr. Bhadra is a scholar activist and a resource person in enormous number of trainings on gender sensitization, human rights, parenting, and so on for central government, different state governments, and NGOs in India. So I request you, Dr. Bula, to kindly take your session. I'm sure you will enlighten everyone here.
Thank you very much. I hope it's audible to everybody. Okay. Next slide. Just a minute. Go to the title slide. The title of the presentation has a subtitle that it means that the community living and mental health promotion. Yeah, but then she has to get up.
I will sit there.
Okay, fine.
You can sit here. Be careful.
Yeah.
Is it
Right,
okay?
right, you are. So, community living and mental health promotion, that is the main topic. But the subtopic is not less important than the topic, that is a sine qua non, meaning the essentially absolute relationship between community living and mental health promotion. So, that is the key in terms of my presentation. Go to the next slide. This is a common question, so starting with it. I mean, theoretically, probably we know, but we need to know practically. Go to the next one. Go to the next one, please. I think some of the material I am covering has already been told, so I'll go quickly in the sense that now 60 to 70 million people in India suffer from common and severe mental disorders. It's alarming to know that India is the world's suicide capital with over 12.6 lakh cases of suicide in a year. Statistics released by the World Health Organization say the average suicide rate in India is 10.9 for every lakh. This is 22 data. 23 is 10.3. We are going ahead with the suicide, something like that. So a report by India, the Times suggests that 12% of the Indian students between the age of 4 and 16 suffer from psychiatric disorders, 20% show signs of mental disorders, out of which 2.5% have serious concerns like autism or bipolar disorder suicides. Bipolar disorder. Suicides increased to 1,70,924 in 22 to 1,64,033. Suicide is the number 2 leading causes of death for college students, accounting for 7.6 of all suicide deaths. This is official data. I would mention one word about the official data because NCRB itself says that we only cover 75 to 80%. So 20% only we know about it. We do not know about the other thing. 20% is covered, 75% is uncovered. So considering alarming number of mental health patients in India, it's necessary to know how equipped are we to address mental health issues in India. There are 0.3 psychiatrists, 0.07 psychologists, and 0.07 social worker per 100,000 people. To compare the ratio of psychiatrists, developed countries is 6.6 per 100,000. Average number of mental hospital globally is 0.04, whereas in case of India it is 0.004. So India is the lowest and the most depressed country in the world. We do not tell people this next one. The slide before that. This is the one. Yeah, okay, thank you. This is a pictorial presentation of India in terms of who's labeling. That is the most depressing country. 1.5 million will suffer. This is a prediction for 26-27 from depression in lifetime. 150 million access in Indians are in need of mental health care and interventions, both short and long term. 42% of private sector employees have general anxiety and disorder, depression. 46% of private sector employees report extreme stress as a result of their work. So getting to work, getting a job is a very difficult thing, it is generally said in India. But after getting a job, to stay stress-free is another job. So that makes life really hell, so to speak. Now, mental health is a very low priority in many places. It's not at all a global priority when it should be a global priority. 1/3 of the countries do not even have a mental health policy or plan, and about half do not have a mental health law. Most countries in the low or middle income group spend less than $2 American per capita on mental health. Many allocate less than 1% of their health budget on mental health. The number of trained health professionals delivering mental health care is grossly insufficient. So we have about one of the highest consumers of social media. We should look at this opposite trends in terms of digital connectivity. I'm for digital connectivity, but not for social media connectivity. Digital connectivity is proper, then mental health will be taken care much better. In the second decade of the 21st century, not much has changed in many countries how they view and deal with mental illness. Despite its enormous societal burden, mental disorders continue to be driven into the shadows by stigma, prejudice, and fear that disclosing affliction may mean job lost, social standing ruined, simply because health and social support services are not available or out of reach for the afflicted and their family. The community context is crucial, so for promoting mental health in and for sustainable development goals, including available resources. Both from a human rights perspective and an economic perspective, it is clear that mental health must be prioritized. See, if we do not prioritize it, we lose what we call potential people. That the potentialities are not being realized when we do not take care of mental health care. When we treat them as, something in 18th century, 17th century, leopards, that means kushto. Leopards were treated like that, and we treat mental health people that. If you're sitting in the bus and somebody, sitting beside you, suddenly he said that, there is a jam in, you started talking. And when you're talking, you mentioned that you have been in a mental hospital for about 6 months or so for rehabilitation. In the next stoppage, the guy gets up and starts standing. So the lady was surprised and said that, why are you standing? The seat is still empty. He said, no, I have to get down. Then 3-4 bus stops went by, the guy didn't get down. She got the message that she said, I was in a rehab for 6 months. This quite often happens. Whatever we say that we deny, no, we are very liberal. Even in the educational community, you have gone to the psychiatrist? Oh, you take medicine? Oh, But if you go to the eye doctor, you take medicine, you go to the intestine problem, you take drink and take liver problem, that's okay. But you have gone to the psychiatrist, you're in a rehab, that's something really what we call achut. You don't come near. So it's a very, very important position in the sense that if the community around us stigmatizes us, there is no way of any mental health care will be effective. I won't go to the next slide, but I'll just go quickly because there's a shortage of time, I understand. Children specifically suffer from these things. Adults do also, but children do specifically. We have seen the teenage students commit suicide more because of the exams and etc. and because of parental's undue expectations. Anxiety disorders, eating disorders, persistent sadness and restlessness, withdrawing from social interactions, hurting oneself for talking about hurting oneself, talking about death or suicide, outburst or extreme irritability, out of control behavior that can be harmful. Children often cannot really understand why are they treated in a discriminated manner, both in schools, in community, etc. So obviously they express more and see that suicide rate is the highest there in India. That means, what does it mean? It means that we are unable to take care of our children to socialize them as productive individuals. If we lose people in their teenagers, if they commit suicide, we're losing some of the future individuals who have been really great. And the potential of the youth is not at all then realized. So this is very grave matter, and we have been actually somewhat, I would say, happy-go-lucky attitude until 2002. We have been quite happy-go-lucky attitude about mental. Pagol, mathay kishu nei. There is something wrong. According to Bollywood, this is the sign. So this sign is that the guy is not working. Next one. Stigma. I will just omit the academic part and go for the Oxford Dictionary definition. Stigma is a mark of disgrace. You know, in 16th or 17th century France, if you do something bad, you are given hot burners in the public. In the public, you are given the punishment. So that stigmatizes the person, that the person has a tattoo. Now we are modern and liberalized, so you think tattoos are mark of fashion, so and so forth. But the tattoos are given by burning those days criminals, so that we know who criminals are. So in a sense, this Oxford Dictionary one says there's a particular person whose bodies have been satanic, that is disgrace, is quality of the person also is disgraced. So stigma is about beliefs and attitudes often derived from the media or around us. Stigma is based on negative views of people simply because they are seen as belonging to a particular group. Stigma often results in fear of members of stigmatized group, often based ignorance and lack of understanding. The last part is very important. Stigma is mostly, 80% research tell us, is based on ignorance and lack of understanding. I mean, it's the other way around. The one we are stigmatizing actually knows, but the one who is stigmatizing does not know what the person is doing. And stigma actually kills people. Stigma makes people lonely, completely disoriented in many things, and unproductive. So stigma arises when someone sees you in a negative way because of a particular characteristic or attribute that they associate when they come to know that you have a mental health issue. The bus incident. When someone treats you in a negative way because of your mental illness, that is discrimination. So the elements of stigma consist of basically three elements: problem of knowledge, ignorance; problem of attitudes, prejudice; problem of behavior, discrimination. So ignorance, prejudice and discrimination. This creates the whole circle of stigma and dehumanization of individual in undesirable social category. I'll go to the table that will make more sense in terms of myths and things. Go to the next one, please. You can see where stigma comes from. There are two types, public and self. Two types, public and self. You can take stereotype, negative belief, prejudice, agreement with belief, discrimination, behavior, response to prejudice. See, most often when we hear something, we don't corroborate or try to corroborate that whether what we heard just is true or not. And if it is true, what kind of action is necessary? We don't do that. So our action becomes also prejudiced, ignorant, and discriminatory. So stereotype, self-stigma is negative belief about self. If you tell someone that you are no good, you cannot do anything, this is not really right, continuously the person will develop that self, that I cannot do many things. There used to be a comedy show in BBC television. It's, the name of the show is, it was very popular in 80s and 90s. Some mothers do have them. Meaning the guy fails in everything, so he said, I am a failure. That BBC show was shown in schools to give indication to teachers and parents that don't do that. Don't try to socialize your child or teach your students saying that you can't do it. The position is you can always do it, you try hard. So this is basically what we can say stigma. Go to the next one. So if stigma is disapproval, that means discrimination against a person based on perceivable social characteristics that serve to distinguish them from other members of a society. See, what stigma does is actually, in the name of discrimination, creates an other. What does other mean? Other is not a person. Other means difference. I am different because I am healthy. I am mentally healthy, physically healthy. So the other person is not, maybe looking physically healthy, but not mentally healthy. So it creates an other. Other means a discrimination. Like Greeks used to call their slaves other. From there it came. That means citizens are Greeks, slaves are others because they are non-citizens. So stigma creates others totally. And result of the process of stigmatization, when stigma is acted upon, enacted stigma, differential and unfair, prejudicial treatment to their disadvantaged one. So stigmas are overt or external deformations, deviations in personal trait, and trait stigmas. Like in when we were a young child, we used to call the Sikh drivers who used to wear turban cabbage. Bengalis had a lot of pejorative words for people from Odisha, people from Punjab, and those are actually stigmatization. This particular word you must have heard, those who are Bengalis, ure. In our childhood, we used to hear ure, and they are generally the maid servants or class 4 staff, etc. That's a trait stigma. You are stigmatizing a particular group of people from a particular place. In fact, Indians are often stigmatized by calling Paki in both North America and UK. They will call you Paki in the street. I was there for 10 years doing 3 degrees, and I was called Paki one other day. So I started counting Pakis, made a report, and proceed to the Minorities Commission. Don't ask for the result. Result was half and half. I didn't hear Pakis anymore, but other people, Indians, heard Pakis. And if you wear sari, that gives them complete authority to say Pakis wearing saris. And they now buy our saris, the most costly saris, handmade saris, 20,000, 30,000 in North America and Europe. So there is this distinction. Next slide. Mental health promotion. Actually, this should be the priority in any case. It's a positive effect. The approach involving any practice that enhances capacity for good mental health for the whole promotion through action at the individual, community, and societal levels. As a student of sociology, I want to point out and emphasize a little bit that if we have number of nurses, it's good, but that will not solve the problem. It will be at the level of the individual, not where the person lives. We have to enter into the house of the person, where he is always told, you are not mentally normal. তুই তো normal না, তুই স্বাভাবিক না, তুই সারাক্ষণ অস্বাভাবিক. So if you say that, the psychiatric nurse doesn't enter your house. So you are not known, the person told all the time, you are not normal. Is this a normal behavior for a woman? And woman doubly. It's not a normal behavior for a woman. Why the woman should talk like that? Don't talk like that. So obviously, it needs the social level, the interpersonal level, where community comes very handy, because community is surrounding you, near people. The next door neighbor may come and say, why the hell you are shouting at your wife from 7 o'clock, now it is 10 o'clock, and you keep shouting in every other sentence and telling how worthless your wife. Divorce her. Why have you kept her if you feel that way? That's called promotion. That's called intervention. It has to be done. We have to be cautious about that. So promoting harmony in the community through social networking. This is the first thing. Reducing levels of violence in the community. আর এই এক থাপ্পড় মারবো কথার যেতে হবে, টেনে এক থাপ্পড় মারবো, সেটা কি জিনিস? মানে হুম উই আর পুশিং, টেনে এক থাপ্পড় মারবো যেটা যেতে হবে। আমরা তো বলি না টেনে একটা গালে চুমু দেবো, উই ডোন্ট সে দ্যাট, বাট টেনে একটা থাপ্পড় মারবো। These words, we laugh at it, but these are very important ones. I'm trying my best, okay. Sometimes it's a problematic matter, okay. Okay, which point? Thappor? Chumu, acha. Thappor and chumu are popular, okay. We never say that, we will give you a slap with all might. Or we never say we will give you a kiss with all affection. Why do you say that I'll give you a slap? I'll slap your face. Why? Why the hell the slap is functional? It's a dysfunctional position. Instead, can you not say, what's your problem? You tell me, let me listen to you, see whether we can come to a negotiation. What is that you're feeling? Tell me. You can tell me. We don't encourage or instill trust. We instill discriminatory behavior. And that's a problematic part. No number of psychiatric nurse per person one will not solve this. The whole community has to be actually sensitized about it. So ensuring people are free from stigma and discrimination, ensuring people understand stigma. I wish your organization makes a big conference on stigma and its very types and how to deal with it. Because it's a most important thing that people are stigmatized from this much to whatever you can stigmatize. Imaginable stigma, unimaginable stigma, half imaginable, whatever, that has to be told and get away with. So engaging in improving the facilities available for the treatment of mental health disorders in the community. Educating people and increasing the knowledge of the community about mental health disorder. See, we still don't have community centers where, let's say, every week, 3 days a week, one psychiatrist comes and there are sessions, just open sessions, like Alcoholic Anonymous. We don't have that. We are afraid, if I go to the psychiatric session, they'll know I am a psychiatric patient. And that most of us take psychiatric drugs or ghumate pari na. In old age, we take sleeping pills. We will not say, no. I don't do that. I sleep. Correct? How is that possible? Are you in heaven? No. Then how do you sleep? Once in heaven, you will sleep. But we keep denial. It's called techniques of neutralization. We neutralize the people stigma. Next one. This probably we can skip within a minute because the last speaker was quite elaborate in it. But I just want to say who has said that. So we need mental health education and awareness campaign, seriously. Environmental modification, playground, parks, healthy school environment, etc. Healthy workplace, life skills education, decision making, problem solving, creative and critical thinking, effective communication, interpersonal skills, self-awareness, etc. Lifestyle and behavioral modification. Actually, lifestyle and behavioral modification should be a general elective course in every. I am still not late. So what we should do actually, now that UGC has opened up a little bit of corner, we should actually tell universities, colleges, that we should have life skill and behavioral modification course, where we can teach students some of the life skills to deal with negativities of life. That will be real education, not giving a degree. These are some of the pointers. I don't want to elaborate because I think you already know. Educate the person with mental illness and their caregivers. If you educate the person who has mental illness, nothing happens. You have to have education for the caregiver also, because caregiver have to understand. Be non-judgmental, educate public to stop believing negative views about a stigma, which is the most difficult thing. Connect with media and educating media at any given opportunity. I'm going to be very critical about media here. Though I have lots of friends in media. Media is very negative. Media does not report psychiatric, psychological problems. Media thinks they report who killed whom and gang rapes and that psychiatric disorders are problem. And human beings are suffering, media doesn't report. Our media is very blind in this case. They think that is actually, you don't have to show the face. You don't have to tell the name. You don't have to tell the area. You can just show how much it is increasing and what things we can do. Tell me one program in one regional TV station which says we will teach how to handle mental health care. It could be done. What's the problem? So many bad shows are in television? No, there is none, because they do not think about it. So support groups at each level is necessary, upgrading of knowledge, and lot of misinformation supporting mental illness still present, myths, negative understanding, etc. Go to the next one. The slides will be, yeah. Look at the slides of myths and facts. It's like calling old people living alone witch. Yeah, so that is exactly what has happened everywhere globally. They were called witches. Old people living alone, shanties, and not always consistent in talking, they were called witches. It's like that. It's mental illness are caused by witchcraft, spells, or possession by demons as the result of punishment of a higher power. God. God doesn't have much work. He is unemployed. So God looks for mentally ill people and punishes them. But God doesn't punish corrupt people, corrupt politicians, etc. Gang rapes, he does not punish. God has no work for them. So this is one real prejudice. Fact is, mental illness are the result of disturbances in usual brain function that lead to difficulties with the control of feelings, thinking, and behaviors. Mental illness are the result of moral failures or lazy. You'll see some people always hear, you are so lazy, you must be mentally ill. But we do not say the person who is overworked, you're overworked, you must be mentally ill. We don't say that. But that goes both ways. It should go both ways because we do not think. No logical understanding here. So mental illness are not caused by a moral failing or laziness. Sometimes people with a mental illness experience severe fatigue or lack of interest as part of illness, not as its cause. We always actually, we have a tendency to mix up, confuse cause with result. Results are not causes. These are National Health Mission, where from I copied this. Don't worry, it is on the net. I thought National Health Mission probably has grown up now. So I have put up this. There is no doubt about it. You can take a picture. I can even send you, don't worry. So mental illness, next one please. Mental illness are caused by the usual stresses of everyday life. Everyday life stresses are normal and necessary for learning and developing life skills. They do not cause mental illness. For some people, severe and persistent stress increases the risk for developing a mental illness. Why do teens, students, commit suicide? Because the expectations on them from parents and other people surrounding them and teachers are too high. And we have a very traditional stick jaw, straight jacket understanding of career. Now we are slightly changing, but that's, we call drops in the ocean. We need to be all our children, doctors, engineers, PhDs, etc., not really painters, artists, etc. Those are khabiki. What will you eat? You will be unemployed. Eh? Engineers are not unemployed. At the moment, the official data is IT techniques, IT professionals, 2 lakhs IT professional official data are unemployed. Chemical engineers doing PhD are unemployed. So all chemical earning has gone to Adani. So there is nothing to get. So obviously we don't talk about facts. We talk about myths. This we have to give up if we really feel community will promote and interpret. Next one. People with mental illness cannot achieve anything. Sometimes a mental illness can make difficult for a person to work. But with proper treatment, a person with a mental illness can work very well. Some of the world's greatest achievers have had a mental illness. We all know that some of the greatest achievers had mental sufferings, came back to it, and then walked. So these are, see, mental illness probably is the most important disorder which is surrounded by myths, prejudices, and discrimination. Together, stigma. I mean, you can tolerate anybody with bypass surgery, with artificial limbs, etc. We cannot actually tolerate mentally ill. I mean, how many of us have the courage to say, I was mentally not well, I had to take medicines, I had to do this and this, and then I became all right. So what? If you have a broken arm and you are 6 weeks in bed, you have a broken arm. After 6 weeks, you get better. That you say, well, I have a broken arm, it is now all right. But we cannot talk about our mind. Being minded people, see, we distinguish ourselves from animal civilization, that we have culture, we have intellect, we have mind, where we give lot less attention, less importance. This is a very catastrophe, a very suggestive contradiction of human civilization and and so-called culture. Skip the next one and go to National Mental Health Program. I'll talk very briefly here because it has been talked about. So it was launched in 1982, major step forward for mental health services. Think about it, 1982, we got freedom in 47, we had our constitution in 1950, 82. So it was a long date. And this was the first time and groundbreaking initiative with the initial phases of the implementation of the program were marred with difficulties. Despite many flaws, one of the important achievements of the program during its first decade was recognition of a district-based model for provision of mental health service. And this is important because this actually takes care or keeps a relation with the community. But it hasn't been successful yet, at all. So the primary aim of this National Health Policy 2017 is to inform, clarify, strengthen and prioritize the role of the government in shaping health system in all dimensions, investments in health, organization of healthcare service, prevention of disease and promotion of good health through across sectoral section, access to technologies, etc., medical pluralism, so on and so forth. But this is the most interesting part. And this we heard in COVID. What we heard in COVID is that we cannot take care of physically ill, forget the mentally ill. This we heard from 24th of March 2020 to 2022 December, that we are unable to take care of physically ill patients. And the mental health care was completely ignored, neglected and bypassed. So what do you expect from government? That's the question. See, more we expect from government, the more we get dependent. It is better to have small community interference, small community level based movement and all these things so that we really understand what a mental health patient go through. You know, a mental health patient go through maximum is loneliness, cannot talk to anyone about their illness. Physically ill people doesn't have that. They can say, I have this, I have that. But mental health people cannot tell. So it is best that we do things from the individual to the community. And community is the best place because community can interfere. Your next door neighbor can interfere. So that would be the model answer. Government hasn't come up with anything of community other than this. In 2001, 241 districts are covered. What is that? It is proposed that the DMHP be expanded to all districts in a phased manner. What phase? How many phased? How many centuries of phased manner? I'll finish within a minute. I'll not talk about DMH. And go to the next one. I want to emphasize on these two and then finish it up. No, yeah. Reducing isolation and stigma. This is the most important two things. One of the most significant barriers to seeking help for mental health issue is the fear of being isolated or stigmatized. Just I said this and I'm emphasizing that this has to be one of the primary goals of a community movement. Because communities that openly discuss mental health and provide a safe space for sharing experiences help break down these barriers. When individuals realize they are not alone in their struggles, they are more likely to seek help and engage in open conversation about their mental well-being. That is why I say there should be community mental health centers, there should be sessions and anonymous. Nobody should tell names. Nobody should try to make it a, Bollywood movie from this. So obviously, creating a sense of belonging will come from reducing isolation and stigma. Next one, please. Shared experience and empathy. Very important. Then emotional regulation and resolution. Resilience. They put a safety net to the person affected. Being able to express feelings and receive empathy from others can aid in emotional regulation. Once I interviewed teenage students as part of a UGC research project. The project aim was to see the impact of new technology on the teenagers. 90% of the teenagers told me first day, can you come at a time when my parents are not there? I said, yes, I can come, you tell me. She said, when they both are there, both are not there, we will tell you something. And I had to go twice, every place. And what conclusion they told me is that the parents do not understand us at all. They don't understand. Whatever we say, either we are mentally disbalanced or we are killing our lives and we are wasting their money, they are working hard for us. They don't understand us. See, if they do not understand, how can I be happy here? So the whole question of resilience comes into point that this is actually very, very important. Parents have to be flexible. You may be an engineer, so what? If you are an engineer, your son has to be an engineer. It's what? If somebody is an actor, that everybody has to be Abhishek Bachchan. And poor guy, every time living in the shadow of his father. Until Amitabh Bachchan dies, Abhishek Bachchan will not be an adult. So that's not what we want. We want productive, independent individuals who can take decisions. That would be resilience. And only community action can give this resilience. Next slide, please. No, skip the next slide. Let's go to the concluding thoughts. Right. Community support plays then a pivotal role in fostering mental well-being by providing the connections, understanding and shared experience that humans inherently seek. Through open conversations, supportive environments, resource sharing, community activities and the power of online communities, we can create spaces where individuals feel heard, valued and supported in their mental health journeys. See, digitally, we can really use it without abusing it. We can really create virtual communities where the people can just talk. People can just write and talk. And that way people might feel that I have someone, I'm getting, bad treatment here. So I'll talk about so-and-so, who is my friend. I don't have to go. So digital can be can give real succor, real comfort if digital wants to. That means those who control the digital wants to. Because in districts of India, server facility is very low. Whatever digital India we're talking about, we are digital India, we're 24% digital. Rest is not. So districts, if we have a server network well, the community action program for mental health, for anything, will be much better. So as we navigate the complexities of modern life, let us remember that we are not alone in our struggles. The power of community support lies in its ability to remind us that we are part of a larger network that cares about our well-being. By fostering this sense of connection, we can collectively contribute to a world where mental health is a priority and every individual feels empowered to seek help, share their experiences, and embrace the journey toward emotional well-being. See, the word empowerment needs redefining, reimagining. The word empowerment doesn't mean that I have a job and standing on my 2 feet. The word empowerment means I have the right, the freedom the strength to tell about my weakness, and other people surrounding me will understand and will not rebuke me or abuse me. So empowerment has been only used very narrowly. It has been a buzzword, but used very narrowly, not yet considered. As I said, mental health is not a priority. But from the Greeks, we know that sound mind in a sound body. Even in our ancient literature also it's there. But we only talk in terms of ancient literature, in terms of building mandirs, not literally knowing the language and reading the indigenous language. It's all there. We could actually do it. So my last point would be, next slide. Thank you very much.
Thank you very much, Dr. Bula. Your speech has been very thought-provoking, and you have covered most of the important aspects of how a community can participate in improving mental health, and what is the seriousness of giving attention to this aspect, highlighting various statistical data of suicide and unhappy society that we are. So how each one of us can participate, and how nurses can participate and contribute in promotion of mental health. And during COVID, it has been identified that mental health was the most important aspect of our life which was seriously affected when we were totally isolated. That even if the child is having COVID, the mother cannot visit the child. So we have seen what impact it has made on those children who were in ICU with COVID and mother crying outside. And we cannot make them meet. And father is sick in ICU and the son cannot meet. And when somebody died in the family, they cannot even perform the rituals. So we have seen the meaning of isolation in the real sense and what it can cause. And it is very clearly stated by WHO now. It is predicted by 2050 that everybody will have effect of COVID-19 on their mental health because they have undergone so much trauma during COVID-19. So I'm sure that all of you are enlightened today that what each one of us can do to improve the mental health and to promote the mental health, identify mental illness, help them to seek help, remove the stigma, remove the discrimination, let it be part of life, let it be like a fracture in your life, and let it overcome. And everybody can become a contributing citizen. And all of us can help, not only professionals, but professionals have higher role to play because the attitudes of professional matters. So each one of us have to correct our attitudes and deal with it and get training. We need to go for training to learn how to deal with it. So now the session is open for questions. Maybe I will take 2 questions because of the overload of activities and less of time.
Maybe one
so
question, ma'am.
Yes, please.
With the professor. Can you talk about the farmer suicide? Maybe 2 minutes. Because farmer suicide, farmer suicide, and largely it is community interventions required.
See, that requires another 2 hours. But, so far, what research suggests us, pharmacy is the weakest one in the sense that we don't produce our medicines.
Farmers. I'm talking about farmers.
FAR-MER.
Agriculture.
Agriculture is okay.
Yes.
I thought you were talking about pharmacy because it is very related. Okay.
No.
In what way though? Then farmer society in what way? In terms of their suicide rate?
No, suicide rates are high. Especially the newer studies have found that farmer suicides are increasing.
Okay. From that point of view?
From that point of view.
Okay, I got it. I heard
and
pharmacy.
community interventions.
Okay. Well, the statistics only as the icing on the cake. the statistics about the farmers, the agricultural workers, are only icing on the cake. Because what happened is that we have not actually given anything to the farmers in terms of developing booster I'll carry on. Oh, no, let them sit down first. Okay. Farmers are neglected group of people in our society. They don't have a high status in a sense that they are not considered that they are the ones who give us food. They are only considered when we see their prices are up. Farmers are not considered that they are one of the backbones of the society, and they should be given these. So naturally, suicide takes place when a person does not have any other recourse. Indian farmers tell us that they don't have much recourse, so they commit suicide. And that's also in a say pathetic that we haven't shown much deep concern or resilience to the farmers, except in one area of India, North India, some statements have been made or some actions have been taken. And that was taken after a long time, long pressure, when actually starving farmers were dying. Starving farmers started to die, and their families also, members also started to die. So, see, actually what India as a country needs, sector-wise, community mental health promotion program, where not only by district, but by profession and occupation, it will be taken care. And also, it will be compulsory for all the community members to contribute. Why do we live in a community? Just for the pujas, just for the some festivals? No, we live in a community to contribute to the enrichment of the community. Self-help program community. We talk about self-help economic program, but we don't talk about creating self-help communities, that communities can help the individual. So I believe it's a very grave crisis and with economic dimensions. But as far as psychological and social dimensions are concerned, we neglect our farmers. We don't think about them. Thank you.
Thank you very much. So we close the session now. Thank you, the organizers, for having this session. And thank you, audience, for being excellent audience. Thank you, ma'am.
The hall is open for discussion. You can have
Discussion close. Okay. One more announcement, sir. We have Dr. T. Dilip Kumar among us. So, sir, welcome to our institution, sir. Thank you. So.
May I request Dr. Sandhya Gupta to kindly felicitate Madam Dr. Bhula Bhadro. I also welcome Dr. K.S. Bharti, Joint Secretary, Indian Nursing Council. Welcome you, Madam, to our institute. I request Ms. Ipshita Roy Mani to kindly felicitate Madam Sandhya Gupta.
এখানেই দাও।
Nothing brings people together like good food. So I invite everyone now to join us over midday refreshments and get a chance to mingle with each other and socialize. We will be back here at sharp 3 p.m. Bon appetit.
No. 2:30 because we are running little bit late. So sorry, you can join. We can join at around 2:30. Yeah. Yes, sir. Okay. কে লিখেছিল?